Hi guys, can you give me a thumbs up if I am loud and clear and if you are able to hear me? Hi guys. Okay, so it seems that we are loud. So I'm going to start with the session. The medicine session will be split into two sessions. Today we will cover around 3 hours and tomorrow we'll be covering around 4 to 5 hours. As I have already told you, the focus will be on PYQs. The simplest reason Hi guys, can you give me a thumbs up if I am loud and clear and if you are able to hear me? Okay. Guys, just give me a second. There is some technical issue. Hi guys. Okay, I think you guys are able to see me loud and clear. So we are starting the session. The session, as I've already told you, we will be splitting into two sessions, one for today and one for tomorrow. Today will be around 3 to 4 hours and tomorrow will be around 4 to 5 hours. As I've already told you, primary focus will be on the PYQs because let us do justice to the students who are going for the upcoming examination. If you have any niggling doubts which are requiring a little deeper conceptual understanding, you can connect to me on the PW Meded Facebook group. Tag me and ask any doubts you have, and we will resolve. And we will also discuss in the subsequent live sessions all that you need to know. Okay, so without wasting the time, let me start with the first question for the day. This is question number 1. Okay, one more important disclaimer or a reminder I should tell that as we go through questions, it is not the question which is important, it is the topic which is going to be important. So we will go little here and there about the topic so that anything coming from this particular topic will be addressed in the upcoming exams. Okay, so this is question number 1. What do we have in this question? We have a 63-year-old male who is brought to the casualty in an unconscious state, right? He is unresponsive, BP is measured, and he is hypotensive, 70/50. Okay, let me ask a question. For all cardiovascular reference point, like if you're talking about any cardiovascular disease, when do you call it as having hypotension? What is the systolic and diastolic cutoff so that you can say patient is in hypotension or hemodynamically unstable? Right, you're all giving the right answer, but let us go a little this side and that side of the question. So when do you call it as hypotension? Okay, patient BP is 96/65. Can we call this as hypotension or hemodynamically unstable? Can we say so? Hemodynamically unstable if 96/65. Can we call it as hemodynamically unstable? Okay, every time you deal with a cardiovascular disease and the word hemodynamically unstable comes into picture, it means we are dealing with a blood pressure of less than 90/60. Okay, so this patient's blood pressure is definitely low, so he is having hypotension or hemodynamically he is unstable. We have got an ECG here, and the question is what is the next step or next line of management? Let me zoom in and show the ECG. Arrhythmic drop, right, less than 90/60. Okay, so what do you find in this ECG? Question number 1. Is this normal sinus rhythm? Is this normal sinus rhythm? If you want to say that this is not normal sinus rhythm, then you guys should be able to define what is normal sinus rhythm. What are the criteria to call it as normal sinus rhythm? And can anybody tell me the difference between just the sinus rhythm and when I use specifically normal sinus rhythm? What is the difference? What is the difference between the sinus rhythm and normal sinus rhythm? Okay, whenever we use the term sinus rhythm, right? Sinus rhythm, what does it mean? Basically, the rhythm is set forth by SA node, right? The onset of the rhythm or the initiation of the rhythm is done by SA node. That's it. Okay. Now, if you have a patient where the rhythm is started by SA node but heart rate is 30, can we call it as normal sinus rhythm? Can we call it as normal sinus rhythm? The answer is no, because heart rate is lower than normal. Similarly, you have a person with the rhythm showing, or rhythm is originating in the SA node, but heart rate is more than 100. Can we call it as normal sinus rhythm? No. But both these conditions, if the onset of rhythm is from the sinus node, can we call it a sinus rhythm? Yes, the onset is from the SA node, so we can call it a sinus rhythm, but depending on the heart rate, we will end up calling it as sinus bradycardia or sinus tachycardia. So what are the criteria to call it as normal sinus rhythm? Number one criteria, how do I get to know that the rhythm is originating from the SA node? What represents the origin of rhythm from the SA node on the ECG? Basically, you need a P wave, right? So there should be P waves on the ECG, and please note that every QRS complex that you see on the ECG should have a preceding P wave, right? There should be no QRS complex which doesn't have a preceding P wave, and every P wave should be leading to formation of a QRS complex, right? So P wave should precede every QRS complex. Why this is important? Okay, and there should be every P wave should lead to a QRS complex. Now what if there is a P wave but it is not followed by a QRS complex? Is it normal? Is it normal? Of course it is not normal, right? It might indicate a AV nodal block. That is why the P wave is not getting conducted into a QRS complex. So then we cannot call such situation. Even when ECG has P waves, but these two criteria are not met, we cannot call it as normal sinus rhythm. Point number one, right? Then the second point is the rate. Rate should be between 60 to 100. 60 to 100, that's a normal physiological rate. 100 plus, even if it is sinus, even if the first criteria is met, we will call it as sinus tachycardia. Less than 60, we will call it as sinus bradycardia, right? And the rhythm should be regular. Rhythm should be regular. Now can anybody tell me, can the rhythm be irregular and still have a normal sinus rhythm? Can the rhythm be irregular, but still we can end up calling it as normal sinus rhythm? Is there any variation with respect to respiration? Is there any variation with respect to respiration? There can be variation, right? But generally, if the documentable variation we see, we use a term. What do we use the term? We call it as sinus arrhythmia. Sinus arrhythmia. So with inspiration, expiration, if you're seeing variation, we will call it a sinus arrhythmia. Okay. It is physiological. Sinus arrhythmia is physiological, but it does not figure into the definition of normal sinus rhythm, right? So these three criteria should be met. Now, this patient has normal sinus rhythm or not? That's the first question. Does this patient have normal sinus rhythm? Right, a tropical Capricorn, right. Increases on inspiration, decreases on expiration. Does this patient have normal sinus rhythm? Can anybody point out P waves in this patient's ECG? Do we have P waves in this patient ECG? Whatever you are seeing here are not P waves, right? These are all T waves. I'm not able to see any P wave. So first criteria to call it as normal sinus rhythm is not met. There are no P waves. First point, right? Second thing is, what is the rate? Is the rate normal or abnormal? Can anybody calculate and tell me the rate? Yes, there are absent P waves, so this is definitely not a sinus rhythm, and so it's not sinus rhythm, so it is not going to be normal sinus rhythm also, right? And you guys should know the calculation of the rate from the ECG, and just by a cursory look in the examination, sometimes you cannot sit and keep calculating the rate. Just by the cursory look, we can clearly say that there is tachycardia. Rate definitely is going to be more than 100, right? Yeah, it is almost 150, 1.5 squares, so it is going to be 150. Now in that case, this is tachycardia. So what all we can agree? We can agree that it is not a normal sinus rhythm. It is not normal sinus rhythm, and there is tachycardia. So basically we are dealing with tachyarrhythmias. And how do we classify tachyarrhythmias? Tachyarrhythmias are broadly classified into two groups for the practical sake of management, right? Tachyarrhythmias are classified into narrow complex tachycardias and broad complex tachycardias. So whenever I say narrow complex tachycardia, what am I referring to? Narrow complex tachycardia, what am I referring to? Am I referring to P wave? Am I referring to PR interval? Am I referring to QRS duration? Right, we are referring to the QRS duration. So what is the normal QRS duration? What is the normal QRS duration? Right, study more, arrhythmic dog, right. So what is the normal QRS duration? Normal QRS duration is going to be, right, all of you are right, QRS less than 120 milliseconds. Yeah, around 90 to 120 milliseconds. So less than 120 milliseconds. So whenever it is less than 120 milliseconds, you can call it as narrow complexes. On the ECG, how do I get to know? On the ECG, right, this one small square I'm talking about, one small square represents what duration? Right, one small square represents roughly 40 milliseconds because the ECG paper speed is 25 millimeter per second. So one small square represents 40 milliseconds. So to say that the complexes are narrow, the QRS, the beginning of Q to the end of S, should occupy less than 3 small squares. Right? In this case, is it occupying less than 3 small squares? Right, study more. Right. Study more, right. Yeah. So this looks like it is occupying less than 3 small squares. 2.5 is what it looks like, right? So this is narrow complex tachycardia. Good. So this is a narrow complex tachycardia. Now that we have understood narrow complex tachycardia, let us make a list of what are narrow complex tachycardias. Number one, your sinus tachycardia is a narrow complex tachycardia, right? Because sinus QRS is going to be less than or in the normal range. Second, you can have supraventricular tachycardias. It's a broad term, to be more precise. It has subheadings, but right now let us not scratch our head. Supraventricular tachycardia. Second thing, when it occurs intermittently, you will call it as paroxysmal supraventricular tachycardia or PSVT. Right. Number third, you can have atrial fibrillation. Atrial fibrillation is also a narrow complex tachycardia. Anything else? Okay, I'll give you a cue. This abnormal rhythm is considered as pathognomonic of COPD patients. So what rhythm I'm talking about? Life in great moment, VT is a broad complex tachycardia. VF is also a broad complex tachycardia. AF we have already discussed, right? Yes, multifocal atrial tachycardia. So you can have what is called as PAT, paroxysmal atrial tachycardia, and then you have another thing called as multifocal atrial tachycardia. Multifocal atrial tachycardia. Now, how do we differentiate between these so that we will get to the answer is a question. I know all of you have answered, but those who are not very familiar will take a quick discussion. Now, what are the broad complex tachycardias? Broad complex tachycardias. VT is one, right? Then VF is one. Yes, junctional tachycardia, yes, you can have a broad complex because it is originating below the AV node, so you can have broad complex. Runge case, right, the multifocal atrial tachycardia is associated with COPD. Okay, is it seen in what? Okay, let me ask one more question. What is the most common ECG abnormality that you see in COPD patients? Most common ECG abnormality in COPD patients. What is the most common ECG abnormality that you see in COPD patient? It is not multifocal atrial tachycardia, right? It is very, very rare. So the commonest ECG abnormality that you will see in COPD patients is sinus tachycardia. They can have right bundle branch block. They can have evidence of the right ventricular hypertrophy, right? Because the right side of the heart is getting affected in COPD, you can have those findings. And because they are hypoxic, they are dyspneic, often they have tachycardia. So tachycardia is the commonest finding that you will get on COPD patients when they come to hospital. Multifocal atrial tachycardia is pathognomonic, but that is not common. It is very, very rare. Okay. Now coming to the wide complex tachycardias, we have VT, VF, SVT with aberrancy. Right. Yeah, right atrial hypertrophy. Right. Can anybody tell me what do I mean by SVT with aberrancy? SVT we listed under narrow complex tachycardia. right? Now, what do I mean by SVT with aberrancy? Okay, so whenever you have a SVT in patients with aberrant conduction, or in other words, bundle branch blocks, we call it as SVT with aberrancy. Okay, why that is important? If you have bundle branch block, right, apart from that M pattern, rabbit tail pattern and all, one of the standard criteria for diagnosis of bundle branch block is WPW syndrome. I'll come there. One of the standard diagnostic criteria for the bundle branch blocks is wide QRS. So these patients, to start with, already they have wide QRS. Once the tachycardia occurs, they still retain that wide QRS. Even when the SVT occurs, their QRS is already wide because of, right? So on the ECG, you will see that it is wide complex tachycardia, and this is one of the common confusion between the SVT with aberrancy versus VT, because VT is a very dangerous arrhythmia. SVT with aberrancy is not that dangerous, so we need to distinguish between that. Okay, and then yeah, you can also have WPW syndrome. Okay, so in SVT there are no P waves, so is in case of atrial fibrillation. Then the second thing is, in case of SVT, okay, I'm checking it, guys. Let me see if there is any issue. Okay. Okay. So there are no P waves in SVT. So there are no P waves in atrial fibrillation also. But the RR interval, that is the main deciding factor. RR interval is going to be regular in case of SVT, right? It's going to be regular. And in case of atrial fibrillation, RR interval is going to be irregular. Irregular. Okay, that is how we identify on the ECG whether it is going to be SVT or atrial fibrillation. Very simple and basic. Now, in case of multifocal atrial tachycardia, it is also going to be irregular, narrow complex tachycardia, irregular rhythm. Now, how do you differentiate between atrial fibrillation and multifocal atrial tachycardia? How do we differentiate between multifocal atrial tachycardia and atrial fibrillation? So, in multifocal atrial tachycardia, P waves are present. So when P waves are present, you might ask me, then why am I calling it as multifocal atrial tachycardia? Why not sinus tachycardia? The reason here is, as the name says, multifocal atrial tachycardia. The rhythm is not started by sinus node. The rhythm is started somewhere on the atrium, at that to multiple locations. So what we see is, we see P waves with three morphologically distinct P waves. So in multifocal atrial tachycardia, we see three morphologically distinct P waves. So P waves are not looking same everywhere, right? At one place, in one complex, the P wave is inverted. In the other complex, P wave is tall and peaking. In another complex, P wave looks like normal. So P waves morphology is changing, and on the irregular narrow complex tachycardia, you should prove that P waves are there, and there are at least three different types of P waves that I'm able to see. Then you can call it as multifocal atrial tachycardia. Clear? So now with this knowledge, let us go back to the ECG and tell me what ECG is this. We have already agreed there is tachycardia and it is not sinus rhythm. Okay, complexes are narrow. We are dealing with narrow complex tachycardia. Ashwin, I'm checking it. Okay. So it is narrow complex tachycardia. Is it SVT or atrial fibrillation or multifocal atrial tachycardia? The moment I said there are no P waves, it is not multifocal atrial tachycardia, right? So we are left between atrial fibrillation and SVT. In both cases, P waves will not be there, but in SVT, the RR interval is going to be regular. In atrial fibrillation, it is going to be irregular. So here, when you look at the RR interval at multiple leads, I'll come there. When you look at this RR interval, does it look regular or irregular? It looks regular, right? It looks regular. So this is a case of SVT, right? Can I call it as PSVT? PSVT only when the history is clearly suggestive that it is intermittent, right? There are history of episodes of tachypnea, episodes of tachycardia, palpitations. Then you can call it as PSVT. Right now, I don't know whether patient had a similar episode in the past, whether he is going to have in the future. I don't know. There is only one index event. So I will call it as SVT. Now coming to some important points about SVT. How do you manage SVT? What is the drug of choice for SVT? Right, so what we are dealing here is SVT, and all of we know that the drug of choice is, what is the drug of choice? Right, adenosine. What is the dose that we will be using? Initial dose that we will be using is 6 milligrams IV rapid push. IV rapid push. Now, why am I saying this? Good. Study more. Good. Right. First dose is 6 milligrams of IV rapid push. One of the important point you need to remember for the exam is what is the contraindication for using adenosine. What is the contraindication for using adenosine? Okay, important contraindication is bronchial asthma or airway hyperresponsiveness. So always make it a point that you ask patient or patient attenders whether there is history of asthma. If there is asthma, COPD is less important, but yeah, any airway hyperresponsiveness can be precipitated and it can lead to bronchospasm. Sometimes it can be catastrophic. You might have to intubate the patient soon after giving adenosine. So always make it a point to ask the history. Sometimes they create a clinical question. Question is like, patient came with SVT, we treated with some drug, after that patient is breathless and on auscultation there is wheeze. Which of the following drug could have been given? They will mention verapamil, then diltiazem and adenosine, right? Those are the alternate drugs we can use, the diltiazem and verapamil. Okay, that is point. Now, yeah, all of you got it right. We need to push it rapidly because adenosine is very quickly metabolized in terms of seconds. It is metabolized in terms of seconds. So if you give it to a peripheral vein and don't push it rapidly, right, it will not reach the heart. Before that, it gets metabolized in circulation. So ideally, as someone mentioned, that preferably use a central line, the vein that is closer to the heart, right, and give a rapid push and flush the cannula with 20 to 30 cc of fluid after that, so that it reaches the heart. Okay, that is one point. If it is failed, right, second dose you can escalate to double. You can make it 12 milligrams IV, again rapid push. IV rapid push. Dr. Atul, I will address it at the end. I will address it. Okay. So IV rapid push, the second dose you can do, right? This is a drug of choice. But can we use it in this patient? Can we use it in this patient? I'm going back to the question. Can we use it in this patient? Okay, pay attention to the BP. Remember, every time a patient has an arrhythmia, if he is hemodynamically unstable, pharmacotherapy doesn't come into picture. We have to shock them, right? Whether you do a synchronized cardioversion or asynchronized shock, that depends on what type of arrhythmia it is. Right, BP is less than 90/60. So this patient is hemodynamically unstable. No role of pharmacotherapy. You have to shock him. Right. Now tell me whether this patient will be conscious when he presented. Most SVT patients will be conscious. They generally don't lose consciousness. So when you have to shock him, right, probably you might have to sedate him. Otherwise, it is very inhumane for us to shock them. SVT, question is BP less than 90/60, right? So it is shock. What shock? Whether it is going to be a synchronized cardioversion or asynchronized shock. Synchronized cardioversion or asynchronized shock. What would you do? And what do you mean by synchronized cardioversion? What do you mean by synchronized cardioversion? Right, we need to do a synchronized cardioversion. Synchronized means the electric energy is discharged on the peak of the R wave. This is basically to prevent an R on T phenomenon. There is something called as R on T phenomenon, which can lead to ventricular tachycardia or ventricular fibrillation. So we have to do a synchronized cardioversion. Now, how do I synchronize? See, if I'm seeing the monitor, I have the pads to discharge the energy, And if I'm seeing the monitor, okay, I see R wave, R wave came, I discharge, but by the time all my sensory system executes this action, the R wave would have passed, right? So how do we synchronize? How do we synchronize? So the basic thing is all our cardioversion machines have a synchronization button. So if you press the synchronization button, you would have already placed the ECG leads on the chest of the patient. So when you discharge the electricity, the machine will wait to pick up the right wave and then discharges energy. So we are not doing anything. So we don't need to really worry much about it. Yes, it is automated. Okay, it is automated. Okay, so now coming back to the question, I think you have all got the gist of it. This patient, BP is low, so there is no way of pharmacotherapy. We are going with DC cardioversion, right? Verapamil can be considered as an alternative to adenosine if there is contraindication. Carotid massage is one of the initial step if the patient was stable, right? If the patient was stable, yes, carotid massage would have been one of the initial steps. Can carotid massage revert all patients of SVT? The answer is no. Even when you see reversal, it is most cases short-lived. That is a practical problem. You do carotid massage, you see on the monitor that heart rate is slowing down, you leave it and few seconds again it picks up back to SVT. So most patients would require either pharmacotherapy or DC cardioversion depending on their hemodynamic stability, right? So this patient needs cardioversion and our correct answer is option A. Good. I'm going to run through some of the ECGs. Let us see if you can diagnose. Okay, what is this ECG now? What is this ECG? Arrhythmic talk, yes, Valsalva can be tried. Any maneuver that increases the vagal tone can slow down the heart rate. So we can try it. But all of them generally do not lead to reversal of the arrhythmia to normal sinus rhythm. Mostly the short sustained result on the monitor is what you see. Okay, so what do we see on this ECG? Question number 1, is it a normal sinus rhythm? Do we see P waves? Okay, what is the best lead to look for P waves? Whether P waves are there or not. What is the best lead? Right, the best lead to look for P waves. Best lead for P waves. Where do you see? Right, either we see in lead 2 or V1. Lead 2 or V1. Lead 2 is the most common thing. And if you look at this ECG, you are seeing that there is one long lead 2 strip. It is what we call as rhythm strip. This is mainly helping us to identify the rhythm, because sometimes when you see the individual leads on top, right, all these leads, only 2 or 3 complexes will be there, and sometimes it is difficult to pick up the rhythm abnormality, right? And because we need to see the P waves, that is why lead 2 is picked up as a rhythm strip. Lead 2 is picked up as rhythm strip. Okay, can we see P waves here? P waves are there. Every P that we can point out is followed by a QRS complex, right? And take up any QRS complex, behind that there is a P wave. Behind that there is a P wave. So that basically means that this is a sinus rhythm. You might see some beat to beat variation in the RR interval. That is probably because of the sinus arrhythmia, right? So this is sinus rhythm for sure. Sinus rhythm. There is beat to beat, sometimes little variation in RR interval. If you see here, it is slowed down, right? Then again it picks up. It is mostly because of the variation in respiration. So you can call it a sinus arrhythmia. Rhythm is definitely sinus. Is it abnormal? No, it is physiological, right? It is physiological. Okay, where do you see a dropped beat? Where is a dropped beat? To call it as a dropped beat, right, there should be a P wave and it should not lead to a QRS complex, right? Here there is increased RR interval, but there is no P wave which has not led to a QRS complex, right? You pick up any QRS complex, behind that I can see a P wave. Pick up any P wave, it is followed by a QRS complex. So it is not, there is no dropped beat, right? This is sinus rhythm. There is variation in RR interval, probably related to patient's respiration. So at best I can call it as sinus arrhythmia, right? And it is physiological, right? This is a normal ECG. This is what most likely we will see in our wards. Okay, now coming to the next ECG. Now tell me, what is this? Just a look at the ECG tells that the rate is definitely more than 100. Okay. And looking at the QRS complexes, you can tell me that it is narrow complex, right? It is only taking maybe 1.5 small squares. So it is narrow complex. It is narrow complex, then it is tachycardia. So we are dealing with a narrow complex tachycardia. So what is it? Atrial fibrillation, SVT, then multifocal atrial tachycardia, paroxysmal atrial tachycardia, sinus tachycardia. What is it? What is it? Yes, there is inferior wall MI changes present to 3 AVF. You can also see reciprocal changes. Study more, right? There is inferior wall MI changes present. I'm mainly concentrating on the rhythm disturbance. Okay, is that a normal sinus rhythm? No, right? Okay, Vivek Sharma, I won't call it as PSVT, right? This is what we learned, right, in the previous section. When you have a narrow complex tachycardia, first thing to see is narrow complex, we know already, 3 small squares for QRS complex. More than 3 small square, we'll call it as broad complex. After that, next we see is RR interval, P waves. Okay, let us start with P waves. P waves present, most likely it is sinus tachycardia, right? Mostly sinus tachycardia is one possibility. Then you can have a paroxysmal atrial tachycardia, or you can have multifocal atrial tachycardia where you might have P waves. P waves absent. You have atrial fibrillation where P waves are not there, and you have SVT where P waves are not there. Now, how do we distinguish between these two? Here, the RR interval is irregular. In case of atrial fibrillation, RR interval is irregular. In case of SVT, RR interval is regular. That's the deciding point. So in this ECG that we have seen, do we see P waves? I cannot clearly identify P waves anywhere. So P waves are not there. So we are not thinking of sinus tachycardia, paroxysmal atrial tachycardia, or multifocal atrial tachycardia. These things are not being considered in the differential diagnosis here because P waves are not there. So we are left with these two options, either atrial fibrillation or SVT. And to distinguish between that, we have to look at the RR interval. So when you look at the RR interval, what is happening here? Is it constant or varying? Okay, look at the RR interval here. Look at the RR interval here. Look at the RR interval here. Here, right? Is it constant or variable? It's varying, right? It is not constant. Right, right. Study more, perfect. So this is a narrow complex tachycardia with irregular RR interval and no P waves. So the diagnosis is atrial fibrillation. Simple. So this ECG is AFib, atrial fibrillation. Cool, good. In me and your communication, I can see that all of you are saying atrial fibrillation. Perfect, right? That's the right diagnosis. Okay, now the next ECG that I'm projecting. What do you think is this ECG showing us? I'm going to zoom and show you the rhythm strip that will give you an idea about what I'm dealing with. I can give you a clue and you will come out with the answer, but I want you to pick up. There are arrow marks pointing towards something. There is an arrow mark pointing here, there is an arrow mark pointing here, there is an arrow mark pointing here, there is an arrow mark pointing here. What is it showing? Study more, perfect, right? So I can see that there is a P wave here. Can you identify that there is a P wave? This P wave looks like it is bifid. It is going down and going up. It is a biped P wave. It is a bifid P wave. Okay. Then look at the P wave here, right? It looks like normal, upright P wave. Upright P wave. Here you can see that the P wave is inverted. So do we have three morphologically distinct type of P waves? Yes, we have, right? We have the rhythm, which is narrow complex, which is irregular, and we have three morphologically distinct P waves. So what is this ECG? This is multifocal atrial tachycardia. Multifocal atrial tachycardia. And as all of you know, this is a pathognomonic ECG finding in COPD, but not the common ECG finding. Pathognomonic, but not common. Got it? Okay. Now, what is this ECG? Anonymous, right? It is MAT. MAT. Pathognomonic ECG finding in COPD. Neelam Bhatia, right? MAT. All of you are right. Leo COPD, perfect. Yeah, okay. Now let us take up this ECG. Point number one, is it sinus rhythm? Number one, is it sinus? Number two, if not, right, complex, whether it is narrow or broad. I think all of us can agree that it is not sinus. I don't find a single P wave anywhere. It is very difficult to find any P wave. So it is not sinus, right? There are no P waves. Then look at the QRS. First of all, you are finding it very difficult to find a P wave. All you are seeing is the QRS complex only. And by a cursory look itself, we can tell that it is definitely more than 3 small squares. It is taking more than 5 small squares. So it is wide QRS. So it is a wide complex tachycardia. Now, what are the important differentials we had for wide complex tachycardia? We thought about VT. We thought about ventricular fibrillation. We thought about SVT with aberrancy. Yeah, someone was asking me to describe what do I mean by SVT with aberrancy. So basically SVT with aberrancy means you have an aberrant conduction pathway, or there is an abnormal conduction which leads to pre-existing wide complexes. Like you have a bundle branch block, pre-existing wide QRS. This is because you have a bundle branch block. Now on top of that, if SVT occurs, because your QRS is already wide, the resultant final arrhythmia will be a wide complex tachycardia. Though you have SVT, because your QRS complexes were already wide because of the bundle branch block, right or left bundle branch block, it is becoming difficult for you to say that this is SVT. It looks more or less like, it is going to look more or less like your VT, right? And differentiating that is a bit of a challenge. It is more of a postgraduate topic. Right now, don't bother about it. Just remember it is one of the differential diagnoses, SVT with aberrancy. And fourth, someone had already mentioned that you can have a WPW syndrome. In WPW also, you have a bundle branch block, like not exactly bundle branch block. You have a wide QRS complex. So you already have wide QRS complex, and on top of that, you develop a supraventricular arrhythmia, like most commonly atrial fibrillation. The end result is you have wide complex tachycardia, which is irregular because atrial fibrillation is occurring and your pre-existing, you had wide complexes. So the result is irregular wide complex tachycardia. WPW with atrial fibrillation or any other supraventricular arrhythmia, you will have wide complex tachycardias. Okay. Now, these two are not the topics that as an undergraduate you need to really bother right now. At least for the upcoming exam, don't bother about WPW with atrial fibrillation diagnosis on ECG. They're not going to ask. If at all they ask, simple thing is you have a wide complex tachycardia which is irregular, and there will be some other history suggestive of WPW. SVT with aberrancy is a pure PG topic. SVT with aberrancy versus VT is a pure PG topic, so don't worry about it. You have to only worry about differentiating between VT and ventricular fibrillation. Both are wide complex. Now, what makes you tell that this is VT and not ventricular fibrillation? What makes you tell that this is VT and not ventricular fibrillation? Okay, you guys are able to hear me, or you're still facing lag issues? Okay, I guess I'm back. So let me know if I'm back, if you're able to hear me loud and clear. Yeah, we'll discuss the causes for SVT. Okay, VT versus ventricular fibrillation. I'll show you one more ECG. Okay, you tell me the differentiation. Okay, I'm not carrying the ECG of VF. What you see in ventricular fibrillation is this. 1 second. Look at this ECG now and tell me what is that you're finding. What is the difference between this ECG and the previous VT ECG? Arun and YT, 3. One small square, one small box I'm referring to is 40 milliseconds. 3 small boxes, 120 milliseconds. So if the beginning of Q to the end of R wave is less than this 3 small boxes, it is narrow complex. If it is taking more than 3 small boxes, it is wide complex. Right, study more, one point is right, irregular and bizarre. Most importantly, for ventricular fibrillation, right, look at the one long lead, something, whichever is they have used as a rhythm strip. In the rhythm strip, you will see the variation in the amplitude is more than 50%. Now, what do I mean by that? See, monomorphic VT looks regular, but in presence of the conduction blocks or pre-existing blocks and all, VT can also look irregular. So VF differentiation is mainly by looking at the amplitude of the complexes. So there will be variation in the amplitude of the complexes which is more than 50%. In the sense, take one set of complexes where the amplitude is very large. Let me just take here large, okay, and look at the amplitude of another segment in the same lead where the amplitude is low. If the variation in the amplitude is more than 50%, like let me say this complex has 5 small squares, right? If the other side the complexes are less than 50% of this, like less than 2.5 small squares, so the variation is more than 50%, then you can call it as ventricular fibrillation. Yeah, by look at it we can say that it is irregular, bizarre, and with the wide complexes I would end up calling it as ventricular fibrillation. But precise definition is there is variation of the amplitudes in the same lead by more than 50%. So it is going up and down, and this variation is more than 50%. We can call it as ventricular fibrillation. Okay, yeah, and if it is twisting around the axis, yes, torsid D point is. Okay, now this patient, right, this ECG that I'm showing you. Now this patient, if he presents with the same hemodynamic parameters, how do you treat? If he presents with the same hemodynamic parameters that previously we discussed, how do you treat? This is VT and this is more precise monomorphic VT because look at all the complexes, they look same, right? Do they look same? Do all complexes look same? Do all complexes look same? So whenever you have to call it as monomorphic, right, you want them to have same morphology in a given lead. From lead to lead variation will be there. Lead to lead variation will be there. So you have to call it as monomorphic, you have to look at the morphology in one lead. In this lead, they're all same. In V1, they're all same. In V6, they're all same. So this is monomorphic VT. If within the same lead, it is wide complex tachycardia, but the morphology is changing and the beat to beat amplitude variation is not more than 50%, then you can call it as polymorphic VT. This is monomorphic VT. Yeah, as a basic rule, whenever you have a patient who is hemodynamically unstable and he has an arrhythmia, you are giving a shock. But is it going to be synchronized or asynchronized? Is it going to be synchronized or asynchronized? Shweta Wagmari, you can drop the question. I'll address it as I find little flexibility in between. Is it going to be synchronized or asynchronized? Which one is more of an emergency, VT or SVT or atrial fibrillation? Even when they are hemodynamically unstable, yeah, VT is life-threatening, right? VT is life-threatening. Here you cannot take a chance, and basically we are doing asynchronized shock. Asynchronized shock. Okay, one last question from the emergency medicine they might ask you. Okay, here is a patient with SVT, he is hemodynamically unstable. Here is another patient with VT, he is hemodynamically unstable, right? For which patient you will follow a step-up approach to cardioversion, and for which patient you will not follow the step-up approach? Yeah, here asynchronized shock is basically defibrillation. Defibrillator is what we are using here. Okay, the other way of saying it is in which condition you will use a step-up approach for cardioversion, and in which cases you will not follow the step-up approach. Now, what do I mean by step-up approach? For example, if you have SVT, right, what you do is you set the button for synchronization and take the lowest available joules or energy for synchronization. Say, for example, if you have 50 as the lowest setting, then you will use 50. You will see whether the rhythm got reverted to sinus. If the rhythm is not reverted to sinus, then you will step up to go to 100. If not, then you go to 150. So you keep trying cardioversion starting with the lowest point. For atrial fibrillation, it's little higher, but we're still starting at low. 100 is what we start for atrial fibrillation. But whenever you have to do defibrillation or an emergency shock, like in case of VT, you choose highest available joules to you. Right? Your machine might have 200, 220, 250, 280, whatever is the joules available. Highest available joules is what you choose and deliver, right? So you're not looking at synchronization, you're not looking at step-up approach. You keep giving the same intensity of energy till you get the rhythm reverted. We will start with, okay, then you might have heard about the biphasic defibrillators and monophasic defibrillators. Which one will you use? Which one is better, biphasic or monophasic? If I have to defibrillate a patient or cardiovert a patient, I should use monophasic or biphasic? Okay, now am I clear? Okay, you guys are able to hear me now? Give me a second, guys. I'm checking what is the issue. Okay, yeah, right. So biphasic is better. Now, why are we preferring biphasic? Still lagging? Okay. Okay, guys, are you able to hear me? OBS पे तो मैं लाइव दिखता हूँ लेकिन जो नहीं दिख रहा है, होपिंग रेट 40 मिलीसेकंड का है, तो शायद उसी की वजह से हो रहा है. ओके. ओके, तो अभी एक ब्रेक के लिए ले लेता हूँ, फिर विल सी. एक ब्रेक के लिए ले लेता हूँ, फिर विल सी. ओके, ठीक है. उनको बता देता हूँ स्टूडेंट्स को. या अभी एक ब्रेक ले लेता हूँ. ठीक है. एनी ओके, मैं आपको एक स्क्रीनशॉट भेज रहा हूँ स्पीड का. हो गया ना? ठीक है. मैं उसके पास लैपटॉप के सामने हूँ. ओके, अभी मैं बाहर दूर हूँ लैपटॉप से. एक्सेस दे दिया है, स्पीड 500 दिखा रहा है, बिना प्रॉब्लम के. ठीक है. Hi guys, you are able to hear me now? Okay, I guess I'm back and I hope you guys are able to hear me out. Okay, cool. So we are live now. पीछे का थोड़ा सा डिस्टर्बेंस होगा, प्लीज़ बेयर विथ मी, क्योंकि इन द क्रोमा रूम देर वॉज लॉट ऑफ इश्यूज. Now we had discussed basics of ECG. We will take it forward from there. I am projecting a images of uh, you can call it as a defibrillator machine. Okay. Now tell me whether this machine is biphasic or monophasic. How do you identify whether it is biphasic or monophasic? You can get these kind of image based questions from the emergency medicine section. So tell me whether this is biphasic or monophasic. This device is biphasic or monophasic. If you have this device, what is the joules that you will be choosing to treat your patient? Hi Deepak Jain. Hi Biswajit. Yeah. So this is a biphasic device or okay, Debu says biphasic. Yes, all of you are right. This is biphasic. Okay. And earlier we agreed that biphasic gives better result when we do cardioversion or defibrillation in comparison to monophasic. What is the reason why biphasic gives better result? Because what we do in monophasic and biphasic is, let me draw a person, right? Okay, these are clavicles. Now what we do, we have two pads. One acts as a positive electrode, other acts as a negative electrode, right? So one is placed somewhere here, the other is placed here. And when you deliver electric impulse using a monophasic, let me call this as monophasic. Monophasic, one of the lead is positive, the other lead is negative. So electrical impulses will move from positive to negative, right? Depending on where is positive, it will move in one direction. As the electrical impulse passes through the heart, right, it will silence most of the myocardial cells. It will silence the electrical activity or stuns it. Okay, once you stunned it, it is like you have stopped the heart for a fraction of a second. Now it is like almost arresting the patient, right? Then why are we doing it? Why are we doing it? Sadimor, yeah, you're right. We are doing it because now you have a conduction system in the heart, SA node, AV node, and the bundle of his Purkinje fibers. And then you have other cells in the heart, myocardial cells. All of them have native ability to generate electrical impulses, right? But automaticity is maximum with which part of this system? Which node? Is it SA node, AV node, Purkinje fibers, or the myocardial cells, which are more likely to have or have a higher automaticity, which can automatically start firing? Obviously the conduction system, and in the conduction system it is SA node, right? So when we stun it, SA node has a better chance of recovery. So for example, this is a heart, right atrium, left atrium, right ventricle, left ventricle. So this particular patient, SA node is not generating the impulse, or somewhere here is a focus. Here is a focus in the ventricle. So that is why has led to VT. From there, electrical impulses are spreading everywhere and patient has developed VT. When we shock it, right, your SA node is silenced, AV node is silenced, and this extra focus is also silenced. But when recovery occurs from this stunning, SA node is the one which is more likely to come back quick and take control of the rhythm. That is why we shock. That is why we shock. But the problem is when we are using monophasic, right, we need to give a large amount of energy to silence most of this ectopic foci. So when you give one shock, maybe 50-60% of the cells which are hyperactive in that ectopic focus will be silenced. So the chances that after you're shocked, rhythm reverting to normal and then again bouncing back to abnormal rhythm is high. So in such cases, you might need to go much higher energy to achieve. But when you give high energy, right, it is electricity. It will cause the tissue burn. It will also cause myocardial injury. It can cause dysfunction. It can cause little reduction in the ejection fraction for some time. So what we do in biphasic is, in biphasic, the lead placement is same, but like let me say this is a positive lead and negative lead. So once you press the button, right, from positive to negative, there is a movement of electrical impulse. As soon as the electrical impulse reaches the other side of the electrode, there is switching of polarity. So the negative becomes positive lead and the positive becomes negative lead. So now what happens, the energy that reached this pad will go back to the other electrode. So first time the electricity goes through the heart, maybe it will clear 50% of hyperactive cells. Then the same electricity is again returning through the heart. So this time it will clear another 20-30%. So because of that it becomes more effective, and because it is passing through the heart 2 times, we can give lesser energy. So the lesser chances of myocardial injury and lesser chances of tissue burn. That is why we use biphasic. Now how to identify a biphasic machine? Biphasic machine generally tops at 200, because you don't need 300 in a biphasic machine, because 200 will traverse through the heart 2 times. So if you see that it is 300 to 80, then it is most likely going to be monophasic. Okay, if it is showing 200, it is biphasic. That's how we can identify a image based question. Okay, good. Now let's move to the next question. In which kind of asthma does nasal polyps commonly occur? Okay, options are extrinsic asthma, brittle asthma, intrinsic asthma, and exercise induced asthma. All of these terminologies are very important and MCQs can be asked based on that. So can anybody give me an answer? Which kind of asthma nasal polyps are commonly associated with? Okay, now can anybody make an attempt to define what is brittle asthma? Let me start with the most serious condition. Brittle asthma. What do we mean by brittle asthma? Dr. Atul Kashyap, yes, you're right. Okay, let us learn few points about individual options. Let me start with brittle asthma first. Simple understanding is brittle asthma means it is brittle, right? Difficult to control, difficult to treat. That's a simple understanding. But what is the objective definition? And can anybody tell me how many types of brittle asthma are there? All of you are right. C is the correct answer. I'll come to that. How many types of brittle asthma are there? Simple understanding, brittle asthma means very brittle, fragile, delicate, right? Unable to control well, unable to treat. But what is the objective definition? There are 2 types of brittle asthma. Okay, so type 1 and type 2. Sometimes in the MCQs they ask which one is more dangerous or which one is associated with higher mortality, right? So type 1 is a type of asthma where it is difficult to control despite optimum use of medications, right? Difficult to control despite optimum medications. So you have covered steroids, you have used inhaled medications, and you are not able to control. But how do I define the difficulty to control? The difficulty to control here is defined by looking at peak expiratory flow rate variation, PEF variation intraday. Like you guys trade, no? You have, some of you may be trading stocks, intraday trading, where in one day you will buy the stocks and sell it. So within one day, what are the changes happening? Peak expiratory flow rate variation, PEFR variation, within a day by more than 40%. Now, what do I mean by that? Let me say PEFR was 400. The peak PEFR is 400. Lowest PEFR is 200. So definitely it is more than 50% variation. 400 to 200, 50% drop, right? That is definitely more than 40%. So this 40% variation is what we objectively use. Okay, if the words are hidden behind me, if you're not able to see, just let me know. Okay. Yes, more than 40% variation between peak topmost good PEFR of the day and the worst PEFR of the day. If it is more than 40%, then that too, despite use of right combination of medications, ensuring patient compliance and still not able to achieve lesser variation in PEFR, that is type 1. Okay. Type 2, these patients have a good control. Good control with precipitous fall in lung functions intermittently. Precipitous, unpredictable fall in lung functions. Fall in lung functions. So that means these patients who are generally doing well, you will not be able to predict that they are not doing well. these patients suddenly will start doing bad, like all of a sudden, without any warning, without any trigger or factor, these people will start experiencing a asthma worse attack. Okay, so now tell me, who is at higher risk of mortality? Is it type 1 or is it type 2 brittle asthma? Who is at higher risk of mortality? Type 1 or type 2? Who is at higher risk of mortality? Who is at higher risk of mortality? Type 1 or type 2? Obviously type 2, right? Type 2 is the one which is associated with higher mortality in comparison to type 1. Okay, that is the definition of brittle asthma. Now another terminology that I am taking up is what you call as exercise induced asthma. Okay, I'm going to ask you one question. First of all, how exercise induces asthma? And the second point is, if someone is having exercise induced asthma, when does he develop a asthma attack? Is it before the exercise is begun, or during the exercise, or after the exercise? When does the asthma attack occurs in exercise induced asthma, and why do they get exercise induced asthma? Okay, type 1 is not responding to conventional medications, but you can predict, right? I know, like early morning is where his PFR is going to be low, right? As the day progresses, his PFR is going to be good. So it is predictable. We can taper and adjust medications according to his need. It is quite predictable condition. Type 2, he is doing well. All of a sudden, like I'm as such an asthmatic patient, but if I had type 2, I'm talking to you and I can right now develop a asthma attack, right? I may not have access to my medications. Unpredictability is what makes type 2 to be associated with higher mortality. Okay, Neelam Bhatia says after the exercise and Anonymous says during. Okay, anybody thinks before the exercise? Like it can happen, right? Like anxiety, stress of performing, I know that I'm asthmatic. Can that trigger an asthma attack? Okay, why exercise induced asthma occurs is, when we are doing exercise, what is happening to our respiratory rate? Is it going to be normal, decreased, or increased? Dr. Tarakandas, yes. Right, so when we are doing exercise, we are generally hyperventilating. And when we hyperventilate, it causes dryness of the airway. All of you have experienced, right? Run for 100 meters and then you will see what happens with your airway, what happens to your breath. We're tachypnic and our airway gets dried. This dryness of airway triggers the degranulation of mast cells. And we know that once mast cells are triggered, that is where the asthma episode occurs. Clear? So why asthma episode occurs in exercise? Because of the dryness of the airway. That, as someone mentioned, yeah, there is a change in the osmolality because of the dryness. And dryness is because of hyperventilation. Hyperventilation is because exercise calls for hyperventilation. But during the exercise, when I'm hyperventilating, I don't get an asthma attack. Usually 10 to 15 minutes after I've stopped the exercise, I develop severe asthma attack. Why is it so? Priya Thakur, right. Right. So when we are doing exercise, right, what happens to adrenaline levels? When we are doing exercise, what happens to adrenaline levels? They are at their peak, right? They are at their best levels. We are pumped, right? Like when you're in the gym, when you're running, you're pumped, your adrenaline levels are high. Now, how do we treat asthma per se? We treat by giving beta agonist only, right? Now, naturally circulating beta agonists are there in the form of adrenaline and other catecholamines. So they will act as a defense against development of a bronchoconstriction. But once we stop exercise, the adrenaline levels start coming down like anything. 10-15 minutes, whatever pump we had is all gone, right? But mast cell degranulation products like histamine and all are still there. Their half-life is relatively longer in comparison to adrenaline. So they're still there in the circulation, they're still there in the airway, and they end up precipitating the bronchoconstriction. So usually exercise induced asthma attack occurs after the exercise. And the reason I'm telling this is, in one of the exam there was a question, which of the following is false about exercise induced asthma, and the statement was precipitous asthma attacks during exercise. That was the false statement. Okay, now coming to this point, extrinsic asthma versus intrinsic asthma. Do we follow this classification today? Do we follow this classification today? Or we have any other classification system for better treatment and understanding of asthma? Priya Thakur, right? Yes. Yeah, bang on spot, right? Do we follow this extrinsic versus intrinsic classification of asthma nowadays, or we have given up and we have some other classification system for asthma? Yeah, we do not follow it anymore because in terms of management it makes less sense, but still, because archaically or historically we were classifying asthma into intrinsic versus extrinsic, we still continue to face questions. Okay, so let us see what is the difference between intrinsic and extrinsic. Extrinsic means the asthma trigger, the source is outside human body, right? It is outside human body. Right, Arunan, right, yes, all your points are correct. Right, so it is basically the trigger is allergy. So exposure to an allergen is a trigger in case of extrinsic. Right, something outside the body. Simple way to remember is extrinsic is something outside the body, extra outside the body is coming and triggering it. Intrinsic asthma, there is nothing allergic, right? There is no role of allergy. Then what could be the reason for this? Right, it could be drug induced or infection triggered. Could be drug induced or infection triggered, some viral infections or drugs. And obviously when we are talking about drugs, which drug is notoriously implicated in asthma? Priya Thakur, right? So obviously it is aspirin, right? We are all aware about, someone was already commenting about Santhosh triad. Aspirin is the most commonly implicated drug for intrinsic asthma. Okay, then extrinsic asthma, as someone had already mentioned, is more common in children, and intrinsic asthma is more common in adults. Intrinsic is more common in adults, extrinsic is more common in children. And you might have heard a statement from the pediatricians that most kids who develop asthma, right, they outgrow their asthma by the time they become teenagers. Some of them might develop asthma again in their late 30s or 40s, but a reasonable number of them continue to be asthma free at least for 1 to 1.5 decades after they become teenagers, post teenagers, the 18-19 years, most of them are free from asthma. Okay, but the intrinsic asthma, they continue to suffer. Like if it is an adult onset asthma with aspirin sensitivity or infection triggered, they continue to suffer from asthma, and it is more difficult to treat. Intrinsic is more difficult to treat in comparison to extrinsic, because extrinsic is triggered by allergy, right? You can have elevated IgE levels. So we have monoclonal antibodies which can target IgE. Your regular drugs are not helping, we still have specialized drugs. For intrinsic asthma, we don't have any specialized drugs. Okay, so that is the basic information we need to know. Now going back to the question, I think it is quite straightforward, right? Drug-induced aspirin Santhosh triad, that is what we are talking about, nasal polyp. So the answer here is intrinsic asthma. Okay, now there are some variants of asthma I want you to remember because MCQs can be asked. Brittle asthma I have already addressed. There is another asthma called as cough variant asthma. Cough variant asthma. Okay, few points you need to know. Which age group is more likely to have cough variant asthma? That is what has appeared in most of the previous MCQs on cough variant asthma. Is it adults or is it pediatric age group? And what is it cough variant asthma? Do they don't have any bronchoconstriction? They don't have any spasm or wheeze? Do they have wheeze? Do they have bronchoconstriction? Okay. So remember, cough variant asthma is more common in children than adults. More common in children than adults. Here we call it as cough variant asthma because they don't come to you because of breathlessness. Most of the asthma patients, they come to you because of two reasons. They are feeling breathless whenever asthma attack is happening. Second, they could hear their own wheeze. They come to you because of wheeze and breathlessness. But these patients are brought to you because they are coughing vigorously, right? So presenting complaint is usually cough. Cough. Obviously it's going to be dry cough. Dry cough, often nocturnal or early morning. Nocturnal or early morning episodes, like parents bring the kids saying that early morning 3:34 he gets up and starts coughing really badly. early morning. Okay. How do we diagnose these patients as asthmatic? The diagnosis is not different from your regular asthma diagnosis. It is PFT or PEFR based. Okay, so PFT, you need to prove that there is obstructive lung disease. FEV1 by FVC, you still need to do. Bronchodilator reversibility test, you still need to do. And based on that, you diagnose. Because there are other causes for cough, in dry cough in kids, right? So diagnosis is just like any other case of the bronchial asthma. And if you hear auscultate, these patients will also have wheeze. But they generally are not becoming so breathless. So that is not a presenting complaint. And second, the kids, they generally won't complain that I'm hearing my wheeze. So that is why they are not presenting features. Cough is what brings them. Okay. Now the last point, occupational asthma. Occupational asthma. Okay. What is the point in the history of the patient that tells you that this patient has occupational asthma? And why is it important for us to differentiate occupational asthma from any other conventional asthma patients? Why is it important? It is important because in a regular asthma patients also, first thing is allergy or something they are exposed to, something is triggering, right? The response is bronchoconstriction. When bronchoconstriction is occurring, right, what is the smooth muscles in the airway doing? They are overworking, right? Like they are in the gym, they are overworking. So over time, when more and more asthma attacks occur, the smooth muscles in the airway are bulked up, right? They are doing that extra work, they are bulked up. So the smooth muscle mass increases in the airway of asthma patients. This is one of the feature, we call it as airway remodeling in asthma. Similar to that, there is increased goblet cell activity, number of goblet cell increases, so more mucus production occurs. The mucus will clog the airways, increase the risk of infection and further damage to the airway. All this put together, something happens what we call as airway remodeling. Once the airway remodeling occurs, it is not fully reversible. So after that, asthma cannot be reversed. But in occupational asthma, something which they are getting exposed to in their workplace is triggering the asthma. So if you remove them from the workplace and rehabilitate them before the airway remodeling occurs, then occupational asthma is completely reversible. But how much time it takes for the airway remodeling to occur? It takes around 6 months. So if the duration of symptoms is less than 6 months, it is reversible. It is reversible. If it is more than 6 months, it is irreversible. So it is very important for us to identify whether we are in the window period for reversibility of the occupational asthma. And what is going to be the history cue? If there is a clinical question, what is a clue that examiner gives you? He will tell that symptoms worse on working days, better on holidays. Symptoms worse on working days, because he goes to work, gets exposed, triggered, he develops the symptoms. When he is taking rest at home, holidays, Sundays, weekends, no work, he is symptom free. That is a very important clincher for occupational asthma, right? And if it is less than 6 months duration, you have a responsibility to rehabilitate the patient so that he is reversed from asthma. He doesn't need to take inhalers lifelong and other medications lifelong. He doesn't need to do multiple hospital visits. But if it is more than 6 months, airway remodeling would have already occurred, then you will treat it like any other case of asthma. Still, you would rehabilitate him because continued exposure means more difficulty to treat asthma. Okay. So that was about the question. But I told you, right, we are not following this intrinsic versus extrinsic classification of asthma anymore. We basically classify asthma into type 2 asthma and non-type 2 asthma. This is the most commonly followed classification system now. Type 2 versus non-type 2. Okay. Why do we call it as type 2? We call it as type 2 because here the Th2 type of T cells are activated. They are the main culprits in triggering the abnormal events that happen. Th2 cell mediated injury, Th2 mediated injury. On the other hand, there is a set of asthma patients where Th2 doesn't play a role. It is the Th1 and Th17 cells which play a role. That is called as non-type 2. And why this is clinically more important today? Because this will dictate how we manage the cases. Okay, just look at this image. Look at the type 2 asthma. These patients are exposed to antigens. Okay, once they are exposed to antigens, the airway epithelium produces something called as TSLP, thymic stromal lymphopoietin. No need to remember. Something is produced by the epithelial cells, which stimulates the Th2 cells. Okay, and these Th2 cells will lead to production of interleukin 4. Okay. Similarly, TSLP stimulates production of other cytokines, which will eventually lead to production of interleukin 5. So there are two important cytokines involved in the pathogenesis of type 2 asthma. What are those? Interleukin 4 and interleukin 5. And if we develop drugs against these, right, we can use them for treatment of this type of asthma. But the other set of patients where interleukin 4 and 5 are not involved in the pathogenesis, use of those drugs is uncalled for. It doesn't give any benefit to us, right? Okay. When you look further down, what interleukin 5 does? Interleukin 5 stimulates the eosinophil production. Eosinophils increase, they are recruited and they cause the inflammation, right? So this type 2, apart from being associated with increased interleukin 4, interleukin 5, there is eosinophilia. There is eosinophilia, right? Okay. As again you see, there is interleukin 4, which is interleukin 5 is stimulating eosinophils. Interleukin 4 is stimulating B cells to produce IgE. So these patients have increased IgE levels, right? Which will stimulate the mast cells to degranulate prostaglandin D2 and histamine. All of that is contributing to inflammation. But when you look at the other side, here the Th1 response is stimulating interferon gamma and TNF alpha, and Th17 response is stimulating some cytokines like interleukins. The net result is recruitment of neutrophils. So it is a neutrophilic inflammation which is responsible for bronchoconstriction in non-type 2. So can we treat these non-type 2 patients with monoclonal antibodies against IL-4, IL-5, IgE? No, right? So that is why it is very important for us to know the we call this as phenotypic classification of asthma, which phenotype your asthma patient belongs to, whether he is type 2 or non-type 2. How can we do that? How do we classify clinically? IL-4 and IL-5 levels are a bit difficult, right? You cannot prescribe it to all patients. Not readily available, costly, not possible. So generally we don't do that. But you can look at IgE levels. You can look at eosinophil levels, eosinophil counts, and also there is a method of assessing the eosinophilic inflammation of the airway. Can anybody tell me how do we assess the eosinophilic inflammation of the airway? Non-invasive method. Non-invasive method. Definitely you will look at IgE levels, you will look at eosinophil count. If you want, you can check the IL-4 and IL-5 levels. But there is a non-invasive way to see whether there is eosinophilic inflammation involved or not. Right, nitric oxide exhalation. So there is something called as fractional exhalation of nitric oxide. So eosinophils, when they are recruited, right, they are generating nitric oxide in their process of inflammation. They are generating nitric oxide. So in the exhaled air, we can quantify the amount of nitric oxide present. Okay, so remember this. This is suggestive of eosinophilic inflammation. So if tomorrow I give a question of a patient presenting with V's and all, and I give a PFT picture which shows FEV1 by FVC less than 70%, obstructive lung disease, bronchodilator reversibility test showing more than 12% increase in the FEV1, asthma hai, done. And I will also tell that we have done pheno, which is elevated. Okay, then what type of asthma it would belong to? Eosinophilic inflammation means obviously it has to be type 2, right? Okay, now can anybody tell me the drugs targeted against interleukin 4, interleukin 5 and IgE? One examples you give from pharmacology. Drugs targeting these interleukins. There are monoclonal antibodies which target these interleukins, right? Can anybody give me examples? I'm waiting for your comments. One very famous, we all know, IgE, right? Omalizumab, right? Anything against IL-4, IL-5? Reslizumab is against which interleukin? Mepolizumab against which interleukin? Mepolizumab against which interleukin? Reslizumab against which? Omalizumab, IgE, right? Right. Mepolizumab against which? Against which? Tarak Das, right. Against which interleukin? There are 4 and 5, right? Right. So remember mepolizumab for IL-5. Okay. IL-4, I want you to remember one drug which is called dupilumab. अगर आपको दिक्कत है to remember, if you have difficulty in remembering, right, it is easy to remember. IL-4, fourth letter of the alphabet is dupilumab. Fourth letter of the alphabet is dupilumab. Okay. So like from pharmacology, you will get a list of most other newly introduced monoclonal antibodies, but these are the names, important things you need to remember. Okay, good. Now coming to the next question. AIDS defining illnesses are all of the following except. Right, yeah. So AIDS defining illnesses are all of the following except. Okay, this is one table from which in last 10 years, at least 10 questions have come in NEET PG. From HIV, most importantly, questions are from the pharmacology. From the clinical medicine side, only few questions come, and the AIDS defining illnesses is one of them. AIDS defining illness is one of them. So options are, we have encephalopathy attributed to HIV, invasive cervical cancer, oral candidiasis, and mycobacterium tuberculosis of any site. Okay, so AIDS defining illness means basically WHO stage 4, or if it is CDC stage that you're looking at, it is stage 3, like an advanced stage, right? Okay, now before going to look at the AIDS defining illnesses, I want to address some other important MCQ points. Then we will come back to the AIDS defining illnesses. HIV is a multi-system disorder, literally from top to bottom. It can affect anything, it can mimic like anything, and it is really a diagnostic challenge if you don't know the HIV status. Okay, these patients can present in varied ways. So there are some important MCQs that can be asked. One question which recently appeared in the NEET super specialty, an image-based question, and the question was, what is the most common dermatological manifestation of HIV? What is the most common dermatological manifestation of HIV? Can anybody tell me what is the most common dermatological manifestation of HIV? Is it a maculopapular rash? Is it psoriasis? Is it something else? Have you seen HIV patients in your OPD? Most of the times, no, when the HIV patients walk into your OPD, something tells your mind that kuch to, like, patient doesn't seem to be like a regular patient walking into your OPD. Something is abnormal, something is striking, and it is something to do with the skin. So what am I talking about? No, Bubo, no. Okay, so I want you to remember one important point. Most common dermatological manifestation is seborrheic dermatitis. Seborrheic dermatitis. Seborrhea or seborrheic dermatitis is the most common manifestation. And I am making a statement which I want you to remember about this. The severity of seborrheic dermatitis correlates with the viral load and CD4 count. More severe is the seborrheic dermatitis, where CD4 count will be lower and viral load will be higher. So that is why I told you, like, as a practitioner, when the patient walks into my OPD, I can guess how bad the patient's situation is by looking at him because of the seborrheic dermatitis, right? It correlates with severity of the HIV. In other words, lower CD4 count and higher viral load. More severe the seborrheic dermatitis, lower the CD4 count, higher the viral load. If such a statement appears in your exam, that's going to be a true statement. Okay. Next question. What is the most common neurological manifestation of HIV? What is the most common neurological manifestation of HIV? Ansh Bansal, fungal infection is not the most common. More than 50% of HIV patients at any given point of time have seborrheic dermatitis. On the other hand, fungal infection, on and off it occurs. So because of that, at any given point, the prevalence of fungal infections is lesser, dermatological fungal infections is lesser in comparison to seborrheic dermatitis. Okay. And HIV is also associated with severe psoriasis. It is not associated with increased risk of psoriasis, but if you have psoriasis and develop HIV, the psoriasis becomes much more severe. Yeah, I will be providing the annotated PDF. Okay, again, infections are not the most common CNS manifestations of HIV. Most common CNS manifestation is cognitive dysfunction. All of the HIV patients will lose their cognitive function. HIV patients may survive without developing an opportunistic infection of the central nervous system, but it is not easy for them to escape from the cognitive dysfunction. Whereas decreased cognition or cognitive dysfunction is the most common neurological manifestation. Yes, they are at risk of increased risk of opportunistic infection. They are at risk of stroke. They are at risk of tubercular meningitis, cryptococcal meningitis, lot of infections. But the most common thing is cognitive dysfunction. Okay, and cognitive dysfunction has a spectrum. It can be mild, and an advanced form of cognitive dysfunction is what earlier we used to call as AIDS dementia complex. AIDS dementia complex. Dementia complex. So when patients have cognitive dysfunction to an extent that they are not independent, their care needs to be taken by somebody else. That is like a more severe form of cognitive dysfunction. I might have a little bit of forgetfulness, I might have a little bit of slowness of my thoughts to start with, but as condition progresses, right, I am forgetting everything. I'm totally dependent on someone to take care of me. That is the most severe end of it, cognitive dysfunction. That is what we used to call as AIDS dementia complex. Okay, so AIDS dementia complex is one of the AIDS defining illness. So if you have an HIV patient who has cognitive dysfunction and to such an extent his life is affected that basic care is taken care by somebody else, it is a case of AIDS, because he has an AIDS defining illness, that is AIDS dementia complex. Okay, there are other terminologies that we use currently for this cognitive dysfunction. It is called HIV associated neurocognitive disorder. Sometimes we use it, HAND. HAND stands for HIV associated neurocognitive disorder, which is further classified into three things. The last stage is again AIDS dementia complex. Okay, now the third MCQ point: what is the most common opportunistic infection for HIV in India and worldwide? What is the most common opportunistic infection in India and worldwide in HIV patients? Is it cryptococcal meningitis? Is it pneumocystis jirovecii? Or is it something else? What is the most common opportunistic infection in HIV patient? Tell me what is it for India, tell me what is it for the world. Anonymous, the current data shows most common opportunistic infection in India as well as world is tuberculosis. India definitely tuberculosis, world also it is tuberculosis. Yeah, you guys may not be able to see what I am writing for world, but it is tuberculosis. You can see it from the annotated PDF. Yeah, worldwide and India it is tuberculosis. That's the most common opportunistic infection. Okay, can anybody tell, should we do a prophylactic treatment for tuberculosis in HIV individuals? Vivek Sharma, no. The current data, the most updated data, it is tuberculosis. Worldwide also it is tuberculosis. Pneumocystis jirovecii is less common. In fact, it is becoming lesser and lesser common because we have better antiretroviral drugs. So you will get pneumocystis jirovecii only when your CD4 count has dropped below 200. Nowadays, we will maintain patients with a good CD4 count. Despite that, they still get tuberculosis because they are already they're exposed. Most of them are exposed. Higher the exposure, higher the chance. Yes, there is a recommendation to give prophylactic treatment for all HIV patients. There are multiple regimens, like single drug INH based regimen or multiple drug based regimen, but there is a recommendation that all HIV patients should be given a 6 months of prophylactic treatment. 6 months only. Why are we giving 6 months only? Why not lifelong? It is not based on CD4 count, like diagnose HIV and de do sabko. The reason for that is most of these patients are not acquiring tuberculosis newly. They are already exposed. They have a latent tuberculosis, right? There is a focus which is latent. As the immunity goes down, it gets activated. So before your immunity goes down, before your tuberculosis gets activated, we will give the drugs so that we are killing the existing latent tubercular bacilli. That's the objective. Yeah, INH based regimens are there. Mostly INH is the center point of prophylaxis for tuberculosis in HIV patients. Okay, now the last point, most common CVS manifestation of HIV. What is the most common CVS manifestation? What is the most common? SNP, yes, right. That's why the regimens are based on INH. But there are some regimens from the Western world which include multiple drugs. For a country like India, INH remains the center point of prophylaxis. Okay, what is the most common CVS manifestation? Okay, I'll tell you what are the manifestations. Number one, they can develop dilated cardiomyopathy, right? They can develop dilated cardiomyopathy. We call it as HIV associated cardiomyopathy. That is one thing. They can develop pericardial effusion. They can develop blocks, conduction blocks. They can develop ischemic heart disease. Now, what is the most common CVS manifestation? No, it is not hypertension. It is not pericardial effusion. It is not dilated cardiomyopathy. It is the chronic ischemic heart disease. Why that is important, right? HIV is associated with often dyslipidemia. One of the parameters that we commonly see in HIV patients is they are dyslipidemic. Partly because of the drugs like protease inhibitors can cause dyslipidemia, plus HIV itself impairs the liver metabolism so that they are dyslipidemic. They have an accelerated atherogenesis. So their atherosclerotic process is accelerated faster than the non-HIV counterpart. Like for 40-year-old individuals, the HIV will develop severe atherosclerosis in next 5 years. The other person would take another 20 years. So there is accelerated atherogenesis triggered by dyslipidemia, which can be partly because of HIV, partly because of the drugs used for treatment of HIV. So because of that, IHD is the most common CVS manifestation in HIV patients. Okay, now going back to the AIDS defining illness. Okay, this is not a very exhaustive list, but these are the important points you need to remember. Okay, then one is Burkitt's lymphoma or the primary CNS lymphoma. That is one. Second, encephalopathy, any form of encephalopathy in an HIV individual. Then remember this is often many students miss it out. Invasive cervical cancer. Invasive cervical cancer is an AIDS defining illness. Candidiasis is a very common infection in HIV patients, but candidiasis of the oral cavity is not considered as an AIDS defining illness. अगर आप भी ना 10 दिन नहीं ब्रश करोगे तो हमको भी हो सकता है. It cannot define a severe immunocompromise. या diabetes हो जाए and you don't control it well, you can get oral candidiasis. Oral candidiasis is relatively common. But when it is invasive candidiasis, when it goes into other structures like esophagus, lung, trachea or bronchi, then it is a AIDS defining illness. Oral is not a AIDS defining illness, right? No oral candidiasis. It is not a AIDS defining illness. Okay. Then other opportunistic infections, but again, I want you to pay attention. Okay. So histoplasmosis, when we are talking about, you can have a isolated pulmonary histoplasmosis. That is not an AIDS defining illness. When the infection spreads beyond the lungs, when it is disseminated or it is occurring without lungs, extra pulmonary focus is where you are seeing, that is an AIDS defining illness. Okay, so remember this, histoplasmosis only pulmonary is not an AIDS defining illness. Candidiasis only oral is not an AIDS defining illness. Okay, then HIV is often associated with severe wasting or cachexia. That is an AIDS defining illness. So when that occurs, that means patient has gone through multiple infections and there is upregulation of inflammatory cytokines which is causing wasting. That's a AIDS defining illness. Then herpes, either meningitis or disseminated infection, not the focal, is a AIDS defining illness. Then your M. avium, M. kansasi, disseminated or extrapulmonary are AIDS defining illness, not the pulmonary ones. Kaposi sarcoma, we all know. Pneumocystis carinii, we know that is definitely AIDS defining illness. CMV pneumonia or retinitis, yes, it is an AIDS defining illness. Again, coming to cryptococcosis, only extrapulmonary is an AIDS defining illness. Cryptococcal meningitis, you can call it as AIDS defining illness. Any other focus of infection, you can call it as AIDS defining illness. Can cryptococcosis affect lung? Have you seen a patient of cryptococcosis of the lung? Have you seen a patient of lung cryptococcosis? Okay, actually I remember an interesting case. So when I was in my PG residency, there was a case referred to the emergency room and the referral doctor had thought that this patient is going through pulmonary embolism. The reason for his thought was patient was grossly breathless. Patient was breathless, tachypneic, very short duration, just few days of duration, like maybe 3 or 4 days, I don't remember exactly. And he had got an echo done. What did echo show? Echo showed that there is right ventricular strain, there is right atrial enlargement, and the pulmonary artery systolic pressure is increased. And when an ECG was done, it showed some non-specific STT changes and the sinus tachycardia. It made him think that this patient may be having pulmonary embolism. Possible. That thing ECG had probably a right bundle branch block, right axis deviation. So it was one of the possible differential diagnosis. So the patient was taken for a VQ scan. VQ scan was non-conclusive, but still the cardiologist thought it could be a case of pulmonary embolism. So he wanted to do a CT pulmonary angio. CT pulmonary angio done, it did not show any embolism. It showed some changes in the lung parenchyma, which the cardiologist did not take it seriously. And he thought it is some routine case of respiratory infection and he was giving antibiotics. Patient did show some improvement. Okay. After that, the case was transferred to my unit, medicine. And our thought was also like KMS pulmonary embolism, ruled out, thought of some LRDI, treated, patient doing well, so it's time for discharge. On the day of discharge, patient started showing convulsions. So as a convulsion workup, we did a lumbar puncture. And lumbar puncture, CS findings were abnormal and the India INC preparation showed cryptococcosis. So that means patient had cryptococcal meningitis. Retrospectively going back and looking at the patient's CT image, there were ground glass opacities everywhere, very commonly seen in cryptococcal pneumonia. Bilateral diffuse ground glass opacities. Something similar is what you see in PCP pneumonia. Now how do I know this was cryptococcal? Because we did the BAL fluid and we stained it and we proved that it is not PCP, it is cryptococcus. So the starting point was cryptococcal pneumonia, later dissemination and developing the cryptococcal meningitis. And when we further inquired, we got to know that patient is a known case of retrovirus and was on ART and off ART for some months. So that is how cases can mimic if we don't take a good history. Okay, but if it is only extrapulmonary, then it is AIDS defining illness. The same patient that I'm talking about, if he did not have cryptococcal meningitis, then I can only call this patient as having HIV but not AIDS. But because she had an extrapulmonary cryptococcosis, we ended up calling it as AIDS. Okay. Then you have a list of other opportunistic infections which can also be considered as AIDS defining illness. This table is going to be very, very important and try to memorize it. Okay. Now having understood this, we are going back to the question. AIDS defining illnesses are all of the following except encephalopathy attributed to HIV. Did we see that on the table? We saw that on the table, right? So it is an AIDS defining illness. Okay. I specifically asked you to remember that invasive cervical cancer is an AIDS defining illness. So that's also true. Okay. Mycobacterial tuberculosis of any site? Yes, it is an AIDS defining illness. Okay. Is oral candidiasis an AIDS defining illness? The answer is no. Invasive esophageal tracheobronchial candidiasis can be considered as AIDS defining illness. Oral, no. So that becomes our correct answer. Option C is the right answer. Cool. Okay, so now let's move to the next question. Something related to HIV again. We have an adult man who has tested positive for, who is an HIV positive and he has presented with fever for 3 weeks. Okay. He has dry cough and significant weight loss. Most of the things are expected in an HIV individual. His chest X-ray is given below and they're asking what is the most likely diagnosis. Okay. Before going through the X-ray, let us read the options. We have staphylococcal pneumonia. We have pneumococcal pneumonia, tuberculosis, and pneumocystis jirovecii pneumonia. Okay, let us see the X-ray and then we will come back to the question. Okay, how many of you are for tuberculosis? Okay. Now, some of the important points here. Okay, yes, tuberculosis is the most common opportunistic infection in HIV. Do we see a focal involvement? See, what is the most common site for tuberculosis involvement? Yeah, we can see diffuse opacities in tuberculosis when it is a miliary tuberculosis, right? It doesn't look like miliary mottling. It doesn't look like fine granular shadows. It looks more little fluffy, right? Okay, some of you are getting it. Some of you are getting it. Yeah, okay. See, HIV, PCP pneumonia is common. Pneumocystis jirovecii is common. Tuberculosis is common. These are all going to be our differential diagnosis. It could be even cryptococcal pneumonia. Those are all differential diagnoses. Yeah, so in tuberculosis, mostly you expect an apical focus, right? In HIV, whenever you see, when they have activation of tuberculosis, you will see some large cavity. They would have history of hemoptysis. Weight loss the HIV patients will have. right? Cachexia is very common in them. If you don't control their viral load well, they're going to go down with their muscle mass. In fact, I have patients where I had to use anabolic steroids to maintain their muscle mass. Otherwise, they were losing everything. They're becoming like this. Fever, HIV patient, quite common. Anything, it can present with fever. So X-ray is the potential clue here. Right. So in tuberculosis, mostly I'm expecting an apical, right apical or the upper lobe changes. Apart from that, I might have additional like hilar lymphadenopathy and all, which I'm not again seeing here. Hemoptysis history is not there. So it's not very strongly suggestive of tuberculosis. Okay. So I am right now keeping it as a differential diagnosis, but I'm not mostly leaning towards it. Okay. Then can it be staphylococcal pneumonia? On X-ray, how staph pneumonia appears? Staph pneumonia can present in three patterns, right? One is it can cause bronchopneumonia, so where there is patchy consolidation here and there. Bronchopneumonia. Second thing it can present is in the form of lobar pneumonia, less likely to present as lobar pneumonia in comparison to pneumococcal pneumonia or Klebsiella. This is less likely to present as lobar. Klebsiella and Streptococcus pneumonia are more likely to present as lobar. Staph less likely but can present. Most commonly presents as bronchopneumonia. This is the most common presentation, bronchopneumonia. Third thing, especially in pediatric age group, what kind of finding you are expecting? Right, in pediatric age group especially, you will see pneumatoceles. Not common in adults, but in pediatric age group, you will see pneumatoceles. Okay, is this a bronchopneumonia pattern? I'm not fully convinced to call it as bronchopneumonia pattern because you will see sparse cotton wool like fluffy shadows when it is bronchopneumonia. Okay, bronchopneumonia is also means there is patchy consolidation. So somewhere you need to see one or two air bronchograms to say that in those patchy areas of opacity there is consolidation. Okay, that I am not seeing here. Definitely to ye lobar pneumonia nahi hai, and I don't see any pneumatoceles. So right now I am also keeping it as less important differential diagnosis. So what are we left with? Pneumococcal pneumonia and pneumocystis jirovecii pneumonia. Pneumococcal pneumonia generally presents as lobar pneumonia most commonly. Less commonly it presents as bronchopneumonia. So do we see that here? No, right? So that's why I am keeping this as a less important differential diagnosis. How pneumocystis jirovecii pneumonia presents? And okay, another important point from the history. Patient has dry cough. Staph pneumonia, they have productive cough, right? Pneumococcal pneumonia, they have productive cough. Klebsiella pneumonia, they have productive cough. Tuberculosis is also often, until and unless it is miliary tuberculosis, it is going to be productive. Most cases of HIV tuberculosis are productive. So here he is having dry cough. Another factor which leans towards pneumocystis jirovecii. Again, looking back at the question, 3 weeks duration. If you look at the 3 weeks duration, I will be left with only these two differential, tuberculosis and pneumocystis, because pneumococcal, by the end of 3 weeks, either patient has been treated well and he is recovering on ventilator, or he's gone home, or he's gone. Pneumococcal pneumonia or staphylococcal pneumonia is not going to be indolent for 3 weeks. 4 or 5 days you are worsening or getting better with whatever treatment you are giving. If you worse, you'll end up in ventilator. If you land up in complication, you may survive for 3 years in the hospital itself. If all goes well, before 3 weeks you are back at home. Unlikely that these patients will have indolent symptoms running for weeks. So these two are differentials. Okay. Now the most common radiological finding that you see in pneumocystis jirovecii pneumonia is ground glass opacities. Not always, but typical, most often they have productive cough. Yeah. Ground glass opacities. Now what do I mean by ground glass opacities? You can see on the X-ray opacities which are very white, like as jet white as this. You can also see the areas in the lung which are like properly black, well aerated lung tissue. But there is something in between. It's neither fully opaque nor fully translucent, neither fully black nor fully white, something in between. That is what we call as ground glass opacities. Why we call them as ground glass opacities? If you right now Google for a word called ground glass, you will see that you might have had some chandeliers or candle glasses in home which are not very transparent. The regular glass is very transparent, but you might have had semi-transparent, or like your windows might have glasses which are not fully transparent. Those are called as ground glasses. So because the translucency is neither fully translucent nor fully opaque, it is somewhere in between. These opacities are called as ground glass opacities. And here it looks like that. These are not like the areas are fully white. Right? They're somewhere in between. So it looks like ground glass opacities. Better way to appreciate ground glass opacities is HRCT, but on the X-ray also you can appreciate. So keeping all these points in mind, the diagnosis I would go with pneumocystis jirovecii pneumonia. Okay, so that is going to be our correct answer. Now coming to the diagnosis for the confirmation, right? How do you confirm? How do you confirm? Okay, from X-ray I am suspecting, but this could be cryptococcal pneumonia also, because I was telling you the story, right? The patient had ground glass opacities on the CT which was missed, but it was not pneumocystis jirovecii. We got to know it only when we investigated further. So how do we investigate further? What are the methods you can diagnose? Yes, we have to go for a ball fluid, because this is usually dry cough, non-productive. It is difficult to get the sample from their affected part of the lung. So we need to go for a bronchoalveolar lavage. And what test you are going to do on the ball fluid? Okay, you can use silver or Jimsa stain. Culture possible, but it's going to take a long time, not routinely followed. And from the serum, you can also look at beta glucan. Right? Generally, serum beta glucan levels will be elevated. So diagnosis is mainly based on ball fluid and demonstration of the organism using stains, silver stain or Jimsa. Okay, or culture. Culture is not commonly followed, not easy to culture. Okay. So that's what we do. Mostly silver staining is what is most commonly used. From the microbiology, I want you to remember the images. You might get images of the silver stain on the question. Okay. And you can have increased beta D glucan. Serum levels of beta D glucan can be elevated. That's a pointer. It is not a confirmatory test. It can point towards the possibility of pneumocystis jirovecii pneumonia. Okay. Now coming to the drug of choice. What is the drug of choice? Right. We need to give the dual strength cotrimoxazole. That's the drug of choice. Cotrimoxazole. Okay. How long you will give it? Dual strength cotrimoxazole. How long you will give it? Yes, invasive candidiasis as well as aspergillosis. Yes, those three conditions. But here, generally, it doesn't create a confusion because the context is very clear, right? If you are thinking about invasive candida in an HIV, mostly it is the esophagus or the upper airway, which the bronchoscope, when you are doing for the ball only, will identify, right? And if you're thinking of aspergillus, that will be typical history of expectoration of those black colonies, and the X-ray would show an aspergilloma, the cavity and aspergilloma, all that would be there. So it is generally not confusing in the right clinical context. HIV presenting with atypical pneumonia, breathlessness, ground glass opacities on X-ray. If I have a beta D glucan which is positive, even if it is not possible, patient is not giving me consent for BAL, I can still treat it as pneumocystis jirovecii pneumonia because beta D glucan supports my diagnosis. Aspergillus typical presentation would be different. Invasive candidiasis, if it is esophageal, I'll do the endoscopy, or if it is bronchial tree, anyway BAL we will be doing, so I'll be finding it out. Right. So initially we give it for 3 weeks, and then we decide about extension as long as CD4 count is less than 200, as someone has Snippo has already mentioned. Okay, so if the patient's CD4 count crosses 200, and remember, it remains sustainably elevated for more than 200 for 6 months, then you can withdraw. Because I start now, things improve, his CD4 count becomes 230, I stop, and 1 or 2 months later his CD4 count drops below 200, he will develop one more attack of pneumocystis jirovecii pneumonia. So you cannot hurriedly take a decision. Achieve a CD4 count of more than 200, sustain it for at least 6 months or 2 separate sampling at interval, and then you can withdraw the cotrimoxazole. Okay. If cotrimoxazole is contraindicated, what alternatives we can think of? What alternative you can think of when it is contraindicated? Was there any drug which was used in the past as an inhaled substance and it is not readily available. It was associated with substandard results and it's not being used anymore. So what drug I'm talking about? Alternative to cotrimoxazole. So there was a drug called pentamidine. Have you heard of it? Right, pentamidine was used as an inhaled agent. Pentamidine, but it is no longer used. It is no longer used for a simple reason. It is not readily available and the results were substandard. So preferred alternatives to are a combination of clindamycin plus primaquine. Okay, so but again please remember, it is difficult to continue clindamycin for long period of time because it is associated with gut dysfunction, opportunistic infections in the gut and other complications. So we generally make an attempt to come back to cotrimoxazole, but just remember that as an alternative. Okay, now moving on to the next question. In the given below statement, all correlate with GB syndrome except it's an inflammatory condition, plasmapheresis is a treatment method, descending paralysis is seen, and it is a demyelinating disorder. So which of them is a false statement? Which is a false statement? Okay, can anybody define tropical Capricorn right, SNPO right? Yes. So can anybody define what is GB syndrome? What is GB syndrome? GBS. So let us summarize what is GBS. It is a infection triggered inflammatory injury to what? Most often the trigger is some infection. Need not always, you may not always be able to find out that okay there was a particular infection, but it can be infection triggered inflammatory injury to nerves, right? Which nerves? Like we have the structure of the nervous system, right? You have central nervous system, peripheral nervous system. So injury is to peripheral nerves, right? Peripheral nerves. Okay, now in what kind of injury is occurring to peripheral nerves? Let me ask you a question. Is it, see now when you look at the nerve, right, some nerves are myelinated, some are non-myelinated. Okay, let us take an example of myelinated nerve. So you have an axon and then there is this myelin sheath, there is this node of Ranvier. We are all familiar with all this structure, right? Okay, nerve can get damaged when axon sheath is injured or the myelin sheath is injured. So in GB syndrome, whether it is affecting, whether there is demyelination occurring or axonal injury occurring. Yeah, antibody mediated obviously, because infection, if it is triggering the injury, it has to be mediated through antibodies. There is no specific direct infection of the peripheral nerves, right? So it has to be an immune mediated. Tropical Capricorn, you are partially right. Okay, so traditionally what we believed was that it is a demyelinating polyneuropathy. Traditionally we believed that there is demyelination, but with the advent of time we started doing these nerve conduction studies and we got to know that all patients who present with GB syndrome do not have demyelination. So based on the electrophysiological studies, we classify the injury to peripheral nerves that is seen in GB syndrome as either demyelinating, okay, or axonal injury or mixed. There can be both demyelination as well as axonal injury or only demyelination. Okay, the classical example type of GB syndrome which is characterized by demyelination is AIDP. What AIDP stands for? Acute inflammatory demyelinating polyneuropathy. The name itself tells you acute inflammatory demyelinating polyneuropathy. So inflammation comes into picture, nerve injury is part of the name, polyneuropathy, that means multiple peripheral nerves are affected and it is demyelinating, right? And please remember, this is a very potential MCQ. What is the most common type based on electrophysiological studies of GB syndrome? Most common type is AIDP, acute inflammatory demyelinating polyneuropathy. Axonal injury can be in the form of two. You hear a term called as aman. Can anybody tell me what is aman? And you also hear a term called as amsan. Aman and amsan. Okay. Aman stands for acute motor axonal neuropathy. So here demyelination is not there. The axons are affected, injured, but only the motor neurons are affected. So acute motor axonal neuropathy. AMSAN stands for a condition where there is acute motor and sensory axonal neuropathy. Both have axonal injury, right? And there is also variants where axonal injury and demyelination can occur. And the typical example I can quote is there is something called as Miller-Fisher syndrome variant of GB syndrome. Miller-Fisher syndrome variant of GB syndrome, which is mixed. There is demyelination also, there is axonal injury also. Okay, clear? Now, how do these patients present? These patients present with rapidly progressing ascending paralysis. That means the paralysis starts distally and then progresses towards the cephalad, right? So legs are the ones which are first affected and then it starts ascending upwards. Why that occurs? Normally, right, like when you talk about diabetic neuropathy, again you say that distal, more affected, distal parts of the hand, distal parts of the leg, what you call as glove and stocking distribution. So injury to nerves, right, usually depends on their length. This is one statement I want you to remember. Longer the nerves are, they are more vulnerable for injury because they're in the length segment, multiple areas can get autoimmune attack, multiple areas of demyelination. Shorter the nerve, less exposure to autoimmune attack. So that is why the distal nerves are more affected. So it starts peripherally or distally and then progresses upwards. That's why we call it as ascending paralysis. Okay. Can anybody give me an example where there is a descending paralysis? Descending paralysis. Where it starts cephalad, somewhere in the head and upper body and then progresses downwards. Example for a descending paralysis. Descending paralysis. Okay. Okay. Yeah, so basically descending paralysis, mainly you will see when the muscles are the primary site of injury, right? Normally when you talk about myopathy, what do you talk? Proximal muscles are more commonly affected than distal muscles. Muscles around the shoulder girdle and hip girdle are called proximal. They are more affected than distal muscles. Most commonly myopathies are proximal. There are only few myopathies where the distal muscles are predominantly affected. So one example we can think of is botulinum toxicity. Botulism, which is a typical example of a descending paralysis. Okay, so obviously the correct answer is right. The descending paralysis is what we don't see. We see ascending paralysis. Okay. First statement is true, right? Inflammatory condition. Yes, we are using that inflammation in the definition itself. Okay, I'll come to treatment later. It is a demyelinating disorder. It is true. Not all cases are demyelinating. If they make a statement saying all GB syndrome cases are demyelinating disorders, it is false, right? But if they say generally demyelinating disorder, yes, because 85% of the cases are AIDP. I forgot to mention the percentage. 85% cases are AIDP. So that's the most common reason. Okay, clear? Now, when you have a patient presenting with this picture, right? Rapidly progressive ascending paralysis, starting distally and then progressing cephalad, which is symmetric because it is an autoimmune attack. It is not an anatomical injury to the nerves, right? Both the sides are kind of equally affected. Symmetry is very, very important. Symmetric. Then we are talking about peripheral nerves, right? So whenever peripheral nerves are affected, you will have a element type of paralysis. If the spinal cord or the brainstem or the cortex is affected, you will have UMN type, right? Anything above the anterior horn cell till your motor cortex is all UMN. Peripheral nerves, roots, they are typical parts of LMN. So whenever you have LMN palsy, a patient presenting with rapidly progressing ascending paralysis, when you examine, what are the findings you are expecting? With respect to deep tendon reflexes, what happens? With respect to tone of the muscle, what happens? With respect to tone of the muscle, what happens? Obviously, we're talking about element, right? So there will be decreased. Sometimes, or in a good number of cases, there will be areflexia. The reflexes are absent. right? And hypotonia, tone will be decreased, hypotonia and areflexia. These are characteristic findings you are expecting. Okay. And when this autoimmune injury targets the peripheral nerves, it won't spare the autonomic nerves. So there can be autonomic nervous system dysfunction. These patients can have a varying heart rate, tachycardia, bradycardia, and other features of autonomic dysfunction. Okay. Apart from that, an important point I want you to remember is that these people can have a sensory deficit. AIDP can have sensory deficit, and the AMSAN variant can have sensory deficit. Only the AMAN, acute motor axonal variant that we discussed, as the name says, right, it is pure motor variant, only their sensory deficit will be not there. But please remember, when there is sensory deficit, it is going to be mild, right? It will be mild and it will be mostly distal. Everything is distal, simple. Peripheral nerves is what we are talking about. And remember, there is a red flag sign. There will be no sharp level, sharp sensory level. Like this, typically like how you see in diabetic neuropathy, no, distally, you cannot clearly say that yeah, iske aage sensations are there, iske piche sensations are not there. The sharp level is not seen. Okay, why is this important? If you see that, okay, there is a patient who has a sharp sensory level, iske niche all the sensation is gone, and above this dermatome all the sensations are preserved. What does it point towards? What does it point towards? It points towards, that's the hallmark of a spinal cord injury, right? It's a hallmark of spinal cord injury. So if you have a sharp sensory level, then this patient may be having a spinal cord injury, not GB syndrome. Right? This is seen with spinal cord injury, sharp sensory level. That's the point. Okay. Now the last point is very important. In GB syndrome, once the ascending paralysis starts, right, it is progressing, but the progress does not continue beyond 4 weeks. It will not continue beyond 4 weeks. So you have a patient who started more than 4 weeks back. Now it is like T10 dermatome. 5th week, I see that the patient's the weakness and sensory thing is progressed to 2 more dermatomes upwards. That is not going to be a case of GB syndrome. GB syndrome, the progression should be complete by 4 weeks. By 4 weeks, he might not have recovered. I don't mean that 4 weeks he would have recovered. He might not have recovered, but the progression would halt, because whatever infection triggered antibodies, as the infection had gone down, the triggering event had gone down, the antibodies would have slowly come down. So they don't progress beyond 4 weeks. Progression beyond 4 weeks goes against the diagnosis of GB syndrome. Okay. So now going back to the question, our answer is descending paralysis because we see a ascending paralysis. Okay. In terms of treatment, what are the options we have? You can think of IVIG and plasmapheresis, right? IVIG and plasmapheresis. Currently, most of the recent studies show that IVIG is slightly superior to plasmapheresis. At least that is what my take based on the published literature. Okay. So that's about the question. Now moving to the next question. Idiopathic thrombocytopenic purpura is best treated with splenectomy, steroids, IV immunoglobulins, or blood transfusion. This is a kind of controversial question, to be very frank, but we will discuss what is it. Idiopathic thrombocytopenic purpura is best treated with splenectomy, steroids, IV immunoglobulins, or blood transfusion, or immune thrombocytopenic purpura. Arunan, good point. That's what I was coming to. Okay. Point number 1, immune thrombocytopenic purpura or idiopathic thrombocytopenic purpura. That means there is thrombocytopenia, which is presumed to be because of antibodies directed against the platelets. Right? Okay. First question, do we need to do bone marrow biopsy for the diagnosis of ITP? Do we need to do the bone marrow biopsy for the diagnosis of ITP? Aruna, no, I'm going to differ slightly from your point of view, but we'll discuss. Do we need bone marrow biopsy for diagnosis? See, we have numerous causes for thrombocytopenia. It could be viral infections, dengue, other viral hemorrhagic fevers, drugs. The drugs example I can think of is heparin-induced thrombocytopenia, or like a very commonly used antibiotic nowadays, linezolid. If used for more than 10 to 14 days, it can cause thrombocytopenia. Drugs, bone marrow failure syndromes, so many malignancies, liver disease. These are all causes for thrombocytopenia. Right? Then how do I differentiate from all those causes of thrombocytopenia and ITP? Do I need a bone marrow biopsy? The answer is no. Okay, there is a American Society of Hematology 2019 guidelines, which shows that no role of bone marrow biopsy, not routinely indicated. Right? In selected set of patients you might consider, because ITP generally occurs in pediatric age group or young adults. If you have someone who is past 60 presenting with the unexplained thrombocytopenia, you might have other causes, right? Other malignancies, especially hematological malignancies, you might have to consider bone marrow. But in a typical setting, it is not required. So it is not routinely indicated. So how do we diagnose? Not routinely indicated. So how do we diagnose? It is a diagnosis of exclusion. Right? It is a diagnosis of exclusion. So you have to basically exclude all other possible causes for thrombocytopenia to say that it is ITP. Right? It is as simple as that. Now, if at all you do bone marrow biopsy, what findings you are going to get? Megakaryocytes will be normal in number, increased or decreased. Megakaryocytes will be normal in number, increased or decreased in the bone marrow in a patient of ITP. What is happening in ITP? There are antibodies directed against the platelets. Whatever triggered, we don't know, but they are destroying the platelets. So the destruction of the platelets is occurring in the peripheral circulation. Spleen plays an important role in the destruction of platelets. Bone marrow, is it affected in ITP? The answer is no. And when your platelets in the peripheral circulation are low, what will happen to megakaryocytes? They are upregulated, right? So most cases, if you do bone marrow biopsy, what you will notice is either megakaryocytes are normal in number or they're increased. They are not depleted. That's what you will see in the bone marrow. Okay, but it is not necessary for the diagnosis. And in terms of management of ITP, right, most of the problem with these patients is severe thrombocytopenia leading to bleeding manifestations and mortality related to that. So that is what we want to prevent. As long as the platelets count is more than 30, we generally don't need to do much, even if it is chronic ITP. If they are maintaining 30 plus, probably we don't need to do much. So most guidelines recommend that when platelet count is less than 30, you need to treat. And the approach is slightly different for acute or a newly diagnosed ITP versus a chronic established ITP. Okay, so if it is acute ITP, acute or newly diagnosed, first line is what we use, steroids. First line is steroids. Okay, and if it is an acute newly diagnosed ITP where platelet count is low and it is causing bleeding manifestations, you need to act aggressively. Like I have a patient, maybe let me say like 15-year-old kid who presented with some unexplained thrombocytopenia and purpuric lesions. I ruled out all possible causes. I did dengue, I took a good drug history, I did all that. Now my conclusion is it is ITP. Okay, but he is otherwise okay, right? He is not having any bleeding manifestations except purpuric changes. His platelet count is good enough, means not severely bad that he is at risk of bleeding, not 5,000, 10,000. So in those cases, steroids are more than enough, right? When the platelet count is less than 30k, generally we start. More than 30k, we generally don't start. Okay, but if in the emergent situation where either you need to take the patient for an invasive procedure, or there is bleeding manifestations, right? Bleeding or invasive procedure planned. In those cases, what we need to do is we need to give IVIG. Okay. The problem with IVIG is it is damn expensive, right? Many Indian parents cannot afford it, but that's what we can offer in addition to support with the transfusions. Platelet transfusions are minimized. Keep the platelet transfusion to as low as possible. Why? Because more transfusions you do, you are exposing more platelet antigens which are coming from some unknown donor, and the chances of antibody flare-up is high. So we have to restrict platelet transfusions and rather try to control the immunity by giving steroids or IVIG. This is what we do for the acute or newly diagnosed ITP. It's not a big problem in pediatric age group because most of them will outgrow the illness. They will not, good number of them will not become chronic ITP, but adults, mostly if they develop ITP, they are going to become chronic ITP. So adults call for a more aggressive treatment. Okay, so if it is chronic ITP, what all we can do, what options we have? Can we give IVIG repeatedly? No, right? First of all, cost becomes a limiting factor and side effects, so we cannot give IVIG repeatedly. So option 1 we can do is we can give immunosuppressants. So what immunosuppressants we can use? Right, azathioprine has been used, not that great, but it has been used. More potent immunosuppressants like rituximab can be used. Many more monoclonal antibodies are coming up, we can consider them. So immunosuppressants is one, apart from steroids I'm talking about. Okay, second thing we can offer is, now there are a class of drugs which will stimulate the thrombopoietin, or which are thrombopoietin analogs. They act like thrombopoietin and stimulate more platelet production or mobilization from the bone marrow to peripheral circulation, right? Thrombopoietin analogs. Can anybody give me an example? Yeah, rituximab is anti-CD20. Yeah. Erythropoietin is a erythropoietin analog, right? Epopoietin. Thrombopoietin analogs. An example which is available, right, that is now available in Indian market is L-Thrombopag. Many new drugs have come. This is one that is readily available in Indian market, L-Thrombopag. Okay, so that can be used. Now the third option is splenectomy. Okay, in the acute setting, when you need to give a real push to platelet count, IVIG are definitely better than steroids. Okay, in the chronic setting, whenever you have to manage the patient in terms of efficacy, right, the best efficacy comes from splenectomy. Immunosuppressants you achieve in decent number of patients the good platelet count. Thrombopoietin analogs, they come with little side effects. There is increased risk of thrombosis and all, but splenectomy is the one which gives the highest reversal rates. So that would be the best treatment that can be offered to chronic ITP. Now the problem with this question is it is not clear, right? They are not asking clearly whether it is acute or chronic that we are dealing with. Okay, but I'm thinking it from the perspective of medicine question, right? I've made a statement saying that adults mostly become chronic. Pediatric, many of them have an episode of ITP and they may not become chronic, but adults mostly become chronic. So keeping that in mind, I'm attributing that this question is more about chronic. The answer might change if the pediatrician takes up the question, but for me, the answer is going to be splenectomy. ITP is best treated with splenectomy, particularly when it is chronic. Clear? Okay, so that's our question number 6. Now let's move to the next question. On chest X-ray of mitral stenosis patient, the chamber that is initially enlarged is, very straightforward question. Left atrium, left ventricle, right ventricle. Which one is the chamber that is initially enlarged in patients with mitral stenosis? Is it LA, RA, left ventricle or right ventricle? Okay, see, simple thing. We know the anatomy of the left and right side of the heart. We know mitral valve is present between left atrium and left ventricle, right? It is supposed to allow the passage of blood that is coming to left atrium from the pulmonary veins and then let it go into the left ventricle, right? That is where it is present. It opens during systole or diastole. With respect to ventricle, the mitral valve opens during ventricular systole or ventricular diastole. When will blood come to the ventricle? During the ventricular diastole, right? It can receive blood only when it is relaxing. So mitral valve opens during ventricular diastole, right? Okay. Now if the mitral valve is stenosed, it is narrow, right? The amount of blood that is coming from the left atrium to left ventricle gets affected. Now the left atrium needs to do more work to squeeze that blood out into the left ventricle. There is stasis from pulmonary veins. Blood is coming into the left atrium, but it is not easily going into left ventricle because the valve is narrow. So what will happen? There is stasis of blood, left atrium starts enlarging. So the first chamber that gets enlarged is left atrium. Okay. After this, once the left atrium gets enlarged, it has limit, right? हर कोई चीज़ का एक लिमिट होती है, how much it can enlarge. So whatever it can accommodate the extra blood, it is now reached its max. After that what will happen? Pulmonary vein से blood आ रहा है to the lungs, it is not easily going into the left ventricle, so the pressure in the LA starts building up, and that pressure eventually gets reflected onto the pulmonary veins. From the pulmonary veins, that pressure is going to get reflected onto the lungs, right? This is what we call as pulmonary venous congestion. That is why dyspnea is the most common presenting symptom of mitral stenosis patients. Earliest chamber to get enlarged is left atrium, right? So going back to the question now, what is the correct answer? Left atrium is the one which gets enlarged first. Will there be enlargement of right atrium and right ventricle in MS patients? In mitral stenosis patients, will there be enlargement of right side of the heart, right atrium and right ventricle? See, when mitral stenosis occurred, right, the left atrium enlarged, pressure in the pulmonary veins increased. So that means the pressure in the lung capillaries increased, right? In the lung capillaries, pressure increased. So what will be the fate of pulmonary artery? Will it find it difficult to make the blood move from the right ventricle to the lungs? Will it have a difficulty? Yes, because at the level of lungs, there is more pressure, right? It is pushing back. Instead of allowing the blood to move easily, it is pushing back. So pulmonary artery pressure increases. If the pulmonary artery pressure is increasing, what will happen to the right ventricle? Right ventricle has to do more work, right? To push the blood into the pulmonary artery, it has to put more effort because the pulmonary artery pressure is increased. So right ventricle develops hypertrophy. When right ventricle develops hypertrophy, will it be able to relax well? So whenever you have a hypertrophy, right, left ventricular hypertrophy or right ventricular hypertrophy, contraction force may be increased, but the relaxation is affected. Simple, imagine. Have you seen people who are spending 6-7 hours in the gym? What do you see? Like they're always walking like this. Their muscles are not relaxed because they're all hypertrophied. Relaxation is affected, right? They're always walking like this. It's not that they're showing off. It's that their muscles have a little difficulty in relaxation compared to the normal individuals. They are more in a state of contraction. So similar happens with the right ventricle. It will not be able to relax well. If it is not able to relax well, then that means the right atrium needs to do more work to push the blood into a non-relaxing right ventricle. So right atrium can get enlarged. That can reflect onto JVP also, right? All this can happen in a mitral stenosis patient, but the starting point is enlargement of left atrium. Clear? So the answer is enlargement of the left atrium. Okay. We'll move to some of the important images that you might get from the mitral stenosis. Okay, so you have the left atrial enlargement, which leads to two important radiological findings, which you are already familiar with. As the left atrium enlarges, normally what you see in the x-rays, there is a small notch here, but as the left atrium enlarges, the left side of the heart, left border of the heart becomes straightened. So straightened left heart border is one of the findings that you will see in mitral stenosis, and sometimes you can have something called as double density sign, because when left atrium enlarges, no, it goes more posteriorly. Right atrium is front, left atrium enlarges behind it. So you get two densities. Okay, so the outer line is of a right atrial enlargement, and you have another inner line which is due to left atrial enlargement. It is called as double density sign. That also you can see on the X-ray. Okay, they might also ask you what is the earliest echo finding in mitral stenosis. I'll show you an image and you tell me what is the finding. I'll tell you the structures. Okay, so what we are seeing here is, this is your left atrium. Okay, this is your left ventricle, this is your right ventricle, somewhere here will be the right atrium, this is the aorta that you are seeing. Okay, and this is your mitral valve. This is basically the same image that I had shown you earlier in reversal. Okay, we had seen this image, no? Okay, if this image, I just reverse it, this is how the echo view is looking at, right? It is showing that there is left atrium here, mitral valve here, left ventricle here, aorta, and somewhere here is the right ventricle. Right atrium is not seen in that particular view. Okay, so what is the finding that you are seeing? Okay, tell me, there is a valve like which is opposing like this, and behind this there is left atrium, which the pressure is building up. When valve is open, right, if it is a stiff, stenosed, not so compliant valve, how will it open? it will dome into the other cavity, right? Like for example, this image that we were talking about. Now if this valve starts getting, it is stenosed and there is pressure from the left atrium on this valve, how will it open? It will mostly open, it becomes like a dome. It opens like a dome. It's opening like a dome. It's not able to completely open because it is stenosed, but pressure, hey, piche say, there is pressure from this side. So it will open like a dome. That is what we call as doming of the valve. That is the earliest sign of mitral stenosis on echocardiography. Doming of the valve. Earliest sign of MS on echo is doming of the, mainly the anterior mitral leaflet, which domes easily. Doming of anterior mitral leaflet. Okay. In this particular view, don't you think it looks like a hockey stick? Does it give the appearance of a hockey stick? It looks like a hockey stick, right? So we call this as hockey stick appearance. So where do we see hockey stick appearance? Hockey stick appearance is seen in patients with mitral stenosis. Hockey stick appearance. Okay. The other two important signs, I don't have the images, I didn't get a copyright free images, but I would recommend that you go through the Google images. They may also be asked as image based questions, right? Other echo findings which can be asked as image based questions. Number one is fish mouth appearance. Fish mouth appearance. So because the mitral valve is not opening well, and when you see through the valve, when your echo probe is going through the valve, that narrow orifice looks like a fish mouth. That's called fish mouth appearance. And the second finding is on a Doppler, echo Doppler, you have something called as candle flame appearance. So just remember these two things and go through the Google images of these, so that if there is an image based question, you will be able to remember. Fish mouth appearance, candle flame appearance. Okay, so that's it for mitral stenosis. Let's go to the next question. Okay, this is something which all of you must be very much familiar with. All of the following statements are true except components of MELD score are creatinine, bilirubin, international normalized ratio, and serum sodium. Is that a false statement? Components of child Turcotte-Pugh score are albumin, bilirubin, INR, ascites, and encephalopathy. Is it true or false? MELD score is used to assess and prioritize patients awaiting the liver transplantation. Is it true or false, or do we use some other scoring system? Okay. The last statement is components of child Turcotte-Pugh are creatinine, bilirubin, international normalized ratio. Which of the following is a false statement? Right. Okay, we'll just quickly take a look at both the scores. But now tell me, which score is more famous now, or which score is most commonly used? Do we use Child-Pugh more commonly for like hepatological patients, or MELD score? Yeah, we mostly use, nowadays MELD score is more commonly used than Child-Pugh Turcotte score. But still, for the sake of exam, we need to remember both. Okay, Child-Pugh Turcotte has four components, right? One is hepatic encephalopathy, and hepatic encephalopathy, here we look at the grade of hepatic encephalopathy, whether it is grade 1, 2, 3 or 4. And an MCQ that can be asked is, what is the criteria that is used to grade hepatic encephalopathy? What is the criteria that is used to grade hepatic encephalopathy? Right, so please remember, based on something called as West Haven criteria, right? It's based on West Haven criteria. Right now the exam is very nearby, so don't bother about this criteria and all, just remember the name. I don't think they will ask you to grade based on the criteria and all, but at least remember the name. West Haven criteria is what we use for grading the encephalopathy. That is one component. Second component is ascites, present or absent, and if it is present, whether it is mild to moderate or severe. Okay. Third component is bilirubin. Fourth component is albumin. Okay. And the last one is your prothrombin time, where you're looking at two things, either looking at INR or whatever is the laboratory cutoff or the baseline of the patient prothrombin time. Uske upar how many seconds it is prolonged. Like laboratory cutoff, let me say 14 seconds. The patient has 18 seconds. So over and above the baseline or the laboratory cutoff, it is increased by 4 seconds. That is what we are saying, the prolongation above the baseline or the INR. These are the components. Okay. And what are the components of MELD score? See, this child-pugh score, we can easily apply it in exams if they ask questions. But it is not easy to apply MELD score because it takes into account the logarithmic scales. We can only put it into a computerized calculator and get to know. So they will never ask you to calculate MELD score. They will only ask you what are the components. But child-pugh score, they may ask you to calculate. Okay. Only 3 components here. One is serum bilirubin, then is INR and creatinine. Right? Serum bilirubin, INR and creatinine. Easy to remember with the mnemonic BIC. You can simply think that MELD score big गई है. Right? आजकल ना जो easily अपने आप को बेच देता है, they are the one which are well accepted. That's why I asked you a point, which is most commonly used, MELD score. क्योंकि वो बिक गई है, BIC बिक गई है, bilirubin, INR and creatinine. It is INR here. There is no role of prothrombin time. Okay. And in case of the child-pugh score, you can remember with the mnemonic EABAP. You can simply say that A aja baap kada hai, like baap A aja, or you can create something mentally, EABAP, where E stands for encephalopathy, ascites, bilirubin, albumin and prothrombin time in the form of either seconds prolongation or INR. Both are there, right? Okay, now let's go back to the question. I'm starting with the option C. MELD score is used to assess and prioritize patients awaiting liver transplantation. Very true. The MELD score came into picture for this purpose. After that, we started using in other conditions. Example I can quote is alcoholic hepatitis. To decide to give steroids or not, either we have something called as Madri's discriminant function score or MELD score. That's what we use to decide whether to give steroids or not. So various cases, scenarios, we are using MELD score, but primarily it was introduced for prioritizing the liver transplantation. So it is a true statement. C is a true statement. Okay. Components of MELD score, option A are creatinine, bilirubin, INR and serum sodium. Do we have serum sodium? Only 3 components. Bik gayi hai MELD score. Right? We don't have a serum sodium involved in our MELD score. So that becomes our correct answer. The B and D are essentially same statements, kind of same statements. The B is a complete statement. All the components are mentioned, right? Albumin, bilirubin, INR, ascites, encephalopathy. And the D only mentions some of them, creatinine, bilirubin, INR. But they are components, right? So these are all true statements. B and D are true statement. Option A is the correct answer because there is no involvement of serum sodium in the MELD score. Okay. CBI, yeah, that's also good. Yeah. Yeah, like whenever CBI enters, they take the control of the thing. So MELD has entered and taken the control of the hepatology scene. Okay, now one last question. To decide to treat with steroids or not in alcoholic hepatitis, what is the cutoff MELD score that we are using? What is the MELD score that we are using to decide to treat or not to treat with steroids in alcoholic hepatitis? Okay, so in alcoholic hepatitis, either we use Madri's discriminant function score 32K upper or 21 plus of MELD score. If it is there, we treat the patient with steroid. If it is less than that, then steroids may be harmful and less beneficial, so we treat them conservatively. Okay, now coming to this question based on ECG, straightforward. Okay, and trust me, one important thing, ECG based questions in the NEET PG had always been easier because there is a lot of build up to the question. The story is there which tells you what is the diagnosis. The ECG is only supporting your conclusion, right? It's like only ECG is given and they're asking you the findings or diagnosis. Such questions have not appeared, so don't scratch too much of your head for ECG. Okay, now let me read the question. 39-year-old male patient complains of weakness, okay, paresthesia and breathing difficulty presented to casualty. Needful investigations were done and the ECG is suggestive of which of these following findings. This is the ECG. Please take a close look at it. Please take a close look at it. Okay, from Arunan, that is what many of us get confused into. So that's why I told ECG, always read it in the context of patient's story. Always read it in the context of patient's story. Okay. Options are hypokalemia, hyperkalemia, hypokalemia, hypocalcemia, and hypercalcemia. Okay. Now the finding here is little like obscured, and some of you may not be able to make it out well. But what you're seeing here, no, this is your T wave, inverted T wave that you are seeing. That is the T wave. T wave is inverted. This is a T wave, and what you're seeing here, no, it's not T wave. This is T. This is T. So what are you seeing there? What are these? What are these? Okay, to think of hypercalcemia in the absence of other striking findings like carpospadial spasm and the spasms elsewhere is a bit difficult. But what you're seeing here is U waves, prominent U waves. See, even if you see a U wave in a normal ECG, which will be like smaller than the amplitude of T wave, rarely we see. But here what we are seeing are these prominent U waves. This is the T wave that we are seeing. I know, that's why I told it's bit of like, until and unless we know, we'll not be able to spot it. But all these inverted things are T waves and the peaking ones are U waves. So where do we see U waves? Where do we see U waves? Where do we see U waves? Hypokalemia, right? So the correct answer here is hypokalemia. Okay. If at all you get a ECG, most likely you're going to get this ECG. I'm telling you why most likely you're going to get this ECG. The reason for that is all our NEET PG exams, when they download the ECG images from standard sources, obviously the National Board of Examination doesn't run a hospital to have a collection. So they download from sources which are copyright free. They also cannot just randomly pick up something from the internet and use, right? So this is the ECG which commonly circulates in the copyright free segment. So if they are putting an ECG, this could be the most likely thing. Okay, so please keep that in mind. Now this is again a very straightforward question, repeated multiple times, and I'm sure all of you will be able to answer. Which of the following condition Osborne waves are seen in ECG? Reformer and Tarakandas. Yeah, see, even if it is not a hereditary condition, hypokalemic periodic paralysis, severe hypokalemia can cause two important things: that severe muscle weakness, right? The patient is having respiratory disturbance because the muscle weakness is affecting his breathing also. And second, it can cause the paralytic ileus. Those are the common things that we need to keep in mind. If it is, if there is hereditary hypokalemic periodic paralysis, yes, that's also. In this case, they have not given the history of recurrence, so probably I would just take it as hypokalemia. Fair enough. Okay, so we are all familiar, right? Where do we see Osborne J waves? Where do we see? We see them in hypothermia. Now my question is, are these findings or the Osborne J wave, what is that? I'll tell you. But now, is it specific for the diagnosis of hypothermia, or do we see it elsewhere? Just give me a few seconds. I'll just sip a drop of water. Is it specific for hypothermia? Answer to हमें hypothermia ही लिखना है. There is no other answer that we would be thinking of. But is it specific? Okay. Now what is this Osborne J wave? In medicine, no, every time look at the name of any finding disease and it gives you a lot of clue. It is talking about Osborne. Generally we call it as Osborne J wave. So something to do with J wave. So पहले हमें पता होना चाहिए where is a J wave, right? Where is a J wave? We have a P wave on our ECG, right? Then we have a PR segment. Then we have a Q wave. Q wave goes into R wave, comes down to form an S wave. S wave reaches the baseline, then becomes the ST segment, and then you have a T wave. What is the J point? J point is a point where the S wave touches the baseline, right? S wave comes to reach back to the baseline. That is what we call as J point. So when we are talking about Osborn J wave, we're talking about some pathology affecting the J point itself, right? What is the pathology that is happening here? What we see is you have a normal P, you have like regular Q. Okay, don't look at the intervals and all. I'm not drawing it with proportions. But as you are going towards the J wave, there is a small positive upsurge. Okay. Then you have a T wave. This positive upsurge at the point of J wave is what you call as Osborn J wave. And where do we see that? Typical answer is hypothermia, but it is not pathognomonic or it is not specific. It can be seen in other conditions. Okay, I'll tell you what are the other conditions, but I'll show you a real ECG of an Osborn J wave. Can you see that? Right, the Q, R, S wave came, it is reaching the baseline, but it is taking a positive upsurge, then culminating into a T wave, right? This positive upsurge is what we call as Osborn J waves. Okay, what are the other conditions where we might see it? You can see it in some patients with acute MI. You can see it in left ventricular hypertrophy. You can see it in Japanese cardiomyopathy, or what you call as Takotsubo cardiomyopathy, and also sometimes in hypercalcemia. Okay, possible MCQs are, one statement might appear asking you whether it is pathognomonic or specific. The answer is no, it can be seen in other conditions. They are classically described with hypothermia. Which electrolyte abnormality can present with Osborn J waves? That is hypercalcemia. Clear? Okay. Now let me take you to the next question. The production of which hormone is increased in obesity? Kind of physiology question, but it's very relevant. Production of which hormone is increased in obesity? Which hormone production is increased in obesity? Is it thyroxine? Is it insulin? Is it adiponectin? Or is it growth hormone? Which one is increased? Okay. Now, how many of you have seen me 7-8 months back? Like, I was taking live classes for Preplada, NEETSS, and like some other platforms. Have you seen me in the previous avatar of mine? Okay, in 5 months, I have dropped down 30 kgs of weight. Okay, the reason I started thinking of dropping down the weight was that I started seeing the impact of some abnormal hormones in my body, and I was really worried about it. I had to quit my previous platform, took a break, did workouts, managed the diet, and then I was able to drop that. So all that was centered around one hormone or abnormality of one hormone. So what am I talking about? Okay, we will address one by one. Thyroxine, if it is increased, you will develop obesity or you will become lean. What is the primary job of thyroxine? Thyroxine is a main regulator of basal metabolic rate, right? It regulates BMR. If the thyroxine level goes up, basal metabolic rate goes up. So you burn larger amount of calories for the same level of activity. So that means thyroxine should cause weight loss. Hyperthyroidism, patients lose weight. Hypothyroidism, patients gain weight. So in obesity, hypothyroidism can be a reason for obesity, but not increased thyroid hormone, right? Hyperthyroidism or thyrotoxicosis is not going to be the reason. So this is not the answer. Okay. Then coming to growth hormone, few important points we need to know. Before the fusion of epiphysis, what is the use of growth hormone? What is the goal? To give you a good vertical height, right? It stimulates the epiphyseal plate to get a good vertical height. So its job is to give you a lean mass, right? It helps you grow vertically rather than horizontally. You don't become flat, you become tall. That's the job of growth hormone. So normally what growth hormone does is it increases muscle mass. It stimulates protein synthesis, right? And it stimulates lipolysis. So it decreases fat mass. Those who are in the gym, right, the athletics who go to the stage and do all this bodybuilding show off, apart from using anabolic steroids, they also abuse growth hormone. It's one of the commonly abused substances because it gives you more muscle and clears your fat. Okay, so growth hormone is not the reason. Like growth hormone deficiency in adults is one of the reason for obesity, right? So it is not going to be increased in patients with obesity. And you also should know that with aging, growth hormone levels keep dropping down. That is why it becomes more and more difficult to lose fat as you start aging. Teenage mein na, you eat, you gain a lot of fat, workout and you drop it easily, right? Chalice, like my age group, it's not going to be that easy because my growth hormone level would be going down. Same with respect to testosterone. As you age, testosterone level starts dropping down, right? So if you have a good amount of growth hormone, you will build more muscle, not obesity. When you have growth hormone deficiency, you develop obesity. Okay, so that is also not the answer. Now we are left with insulin and adiponectin. Can anybody tell me something about Tarakan Das? Yes, few things which stimulate growth hormone secretion. I'm just going to physiology, but important points. Fasting stimulates growth hormone secretion. Okay, then a good sleep, because maximum growth hormone production occurs during sleep. Good sleep stimulates growth hormone secretion. Okay, exercise, yes, it increases growth hormone secretion. So when you go to gym, your testosterone and growth hormone is going up after the exercise. That is what is helping you to build more muscle. On the other hand, like protein intake or amino acids increases growth hormone secretion. You know, when you are doing the growth hormone adequacy test, sometimes you give arginine to see whether the growth hormone production is adequate or not. To stimulate growth hormone secretion, you give arginine, because amino acids stimulate growth hormone secretion. On the other hand, carbohydrates suppress growth hormone secretion. Sleeplessness suppresses growth hormone secretion. आप entrance exam के preparation start कर दो, and when you finish, when you are getting the seat, when you look at yourself, round face, obese body. The reason is sleepless nights, your growth hormone is tanked down, you put more fat, less muscle. Clear? So आज से when you are in the preparatory phase, right, eat more proteins and less simple carbohydrates. The moment your blood sugar shoots up, your growth hormone tanks down, which is not a good sign. Okay, and also testosterone tanks down for a male, which is not a good sign, right? बहुत काम रुक जाएंगे. Okay, now coming to these two hormones, adiponectin and insulin. Okay, can anybody tell me the role of adiponectin? Tarakan Das, right, protein intake. Role of adiponectin. What adiponectin does? What adiponectin does? You hear two lipocytokines, right, produced by our adipocytokines. One is leptin, adiponectin, right? Intermittent fasting, yes, the longer you fast, right, you have better growth hormone profile. Tarakan Das, right, spot on. Adiponectin increases insulin sensitivity. It facilitates tissue utilization of calories. Okay. Okay. On the other hand, what leptin does? What leptin does? Okay, in obesity, what happens to leptin? Is it increased or normal or decreased? Okay, so what leptin does is, leptin is basically a hormone which tells that whether your fat reserve is adequate or not. Like millions of years back, when our ancestors were not having access to food on a daily basis, right? They were hunters, they used to hunt into the forest, and the survival was a challenge. They used to get access to food once in a week or so, right? They were not eating daily because it is not possible to hunt an animal on a daily basis. That to humans being weak and animals being powerful. So the body was tuned to reserve energy in the form of fat. But how much is adequate? That sense comes from the leptin. So as you start packing adequate fat, the leptins will tell that the fat storage is adequate, calorie pushing into the storage mode should come down. But what happens in obesity is there is leptin resistance. So leptin fails to convey the regulatory system that there is adequate fat, and you keep adding fat. So leptin goes up. Okay, adiponectin is the one which increases insulin sensitivity and calorie consumption. In obesity, it may be down. If it increases insulin sensitivity and reduces the chance of obesity. So the one hormone that is increased in obesity here among the options given is insulin. And right now we believe that insulin resistance is a crux of so many lifestyle disorders. See, once you develop insulin resistance, what body does? What is insulin resistance? Your tissues are not able to utilize glucose because insulin is not able to facilitate acceptance of glucose for burning. So because the tissue penetration of the glucose is poor, circulating blood glucose level is remaining high, and because the circulating blood levels are of glucose is remaining high, the pancreatic beta cells are getting to know it, they are sensing. And how do they respond? They respond by more insulin production, so that they overcome this resistance. We call in the layman term that whipping the limping horse. The beta cells are already tired of producing so much of insulin, but the circulating high glucose levels are stimulating it further, right? At some point of time, the beta cell mass extinguishes, like they come down, and you no longer have a good control on glucose. So if you improve the insulin sensitivity, all this problem will go down. And if insulin is in excess, how is it going to work? It will convert all your circulating blood glucose into glycogen and, most importantly, fat. So insulin is a fat forming hormone. So when insulin goes up, your adipose tissue goes up. When growth hormone goes up, adipose tissue comes down and your muscle mass goes up, right? So insulin resistance is a crux. So if you are in a stage of 30-35 years of age, and if you start noticing the signs of insulin resistance, right, it is a time for you to act on your health. Give another 3-4 years, you are full-fledged diabetic, obese, and it is very difficult. But when you have early stage of insulin resistance, losing adipose tissue, losing weight, keeping yourself physically active can help you revert or prevent progression to overt diabetes. Okay, so what are the signs of insulin resistance that we can get to know? Earliest findings, telltale findings are, you can develop acanthosis nigricans and you can develop skin tags. The moment I started noticing these, up to I'm done, right? I had to start working on my fitness. Keep this in mind. Insulin resistance is crux of so many lifestyle problems, including coronary vascular disease. Because how insulin is going to work? It will convert all your excess calories into fat, deposit in the arteries, deposit in the tissues, deposit in the subcutaneous plane, deposit in the liver, cause non-alcoholic steatohepatitis, everything. So treat the insulin resistance and your problem is over. Okay, so how do we treat? One is the lifestyle improvement, physical activity, low glycemic index carb consumption, increased protein intake, all those things. Is there any drug that will work by increasing insulin sensitivity, which is approved for treatment of pre-diabetic patients? SNPO, right? Yeah, there will be burnt out beta cells. Right, so right now, the FDA has approved, an American Diabetes Association recommends that we should be using metformin for pre-diabetic patients to prevent them from progressing to diabetes. Why? Because metformin works by increasing insulin sensitivity or by decreasing insulin resistance, right? Okay, is there any test apart from this clinical judgments? Is there any test that we can do for diagnosis of insulin resistance? Is there any test that we can use for diagnosis of insulin resistance? Okay, details are not required, but this test is becoming relatively common. So just remember the name, HOMA-IR. HOMA-IR is a test that we use for assessing insulin sensitivity or resistance. Insulin resistance testing. If at all some crackpot examiner asks you this question, because it is becoming common nowadays. Now, if you go to dermatologists also, and you say that there is some hyperpigmentation here and there, first thing they will tell you is do HOMA-IR and come back, because I want to know the insulin sensitivity. It will influence the management. Instead of, see, do you think this acanthosis nigricans will respond to laser and all? No, it's not going to respond. Only when you improve your insulin sensitivity, it will disappear. Okay, and once you know this, no, every time you're traveling in metro and you see your friends, you will be looking at their necks and you will pick up a lot of patients who need attention. Okay, good. So insulin is the one which is increased because of insulin resistance. So that's going to be our answer for this question. Okay, leptin will also be increased, adiponectin will be down, growth hormone may be down, thyroxine may be down in obese patients. Okay, next question. This should be very easy for all of you. The ECG shown below correlates with which of the following conditions? We have discussed about it, so this is not going to be very difficult. HOMA-IR. IR stands for insulin resistance. No need to remember more things. That's enough. Okay, what is this ECG? Very straightforward, right? This is typical monomorphic ventricular tachycardia. Broad complexes, high rate, tachycardia is there. Only rhythm strip is what they have given, and they look all similar. So this is ventricular tachycardia. There is no variation in the amplitude, so I won't call it as ventricular fibrillation. I can't call it as misplaced leads. To tell that this is misplaced leads, I need to see the 12 lead ECG. Then only misplaced leads come into picture. So that is not the option. Definitely not normal, because normal may at least you should have P waves, QRS complexes, T wave, all that things should be there. Nothing is there. Between VT and VF we have discussed, right? VT broad complex tachycardia, VF broad complex tachycardia, but varying amplitude with more than 50% variation in the amplitude. We are not seeing there. Amplitude is same. So the answer is ventricular tachycardia. Clear? Okay, now coming to the next question, a very interesting question. I like this particularly. Trigeminal neuralgia correlates with all of the below features except. Trigeminal neuralgia correlates with all of the below features except. More common in females. Okay, is that true? I don't know, but like overall, generally speaking, we say that headaches are more common in females, right? And if you ask males, they will say that headaches are more common because of females. I'm just kidding, not being gender biased here, but yeah, many headaches like tension type of headache, migraines, most of the headaches are relatively more common in females. So whether it applies to trigeminal neuralgia also, we will see. Okay, pain along the V2 and V3 segments of the trigeminal nerve, is it what is most commonly affected, or is it V1 segment which is most commonly affected? We have three segments of trigeminal nerve, right? V1, V2, V3. So which one is affected? We should know. Okay, then there is no objective signs of sensory loss. There is no objective signs of sensory loss. So like affected area, there is no loss of sensation. Is that what we see in trigeminal neuralgia, or will there be loss of sensation? Okay, last point is the pain, whether it is going to be superficial or deep-seated. Which of this is a false statement, or all of them are correct except? What do you think? What do you think? I think I'm lagging behind you guys by like solid 30 to 45 seconds. I will wait a few seconds for you to reach this part of the video. Okay, trigeminal neuralgia correlates with all of the following features except. Okay, now before I discuss more about trigeminal neuralgia, I want to know from you which diagnosis you would consider as the closest differential diagnosis for trigeminal neuralgia. Like, will I be confused between migraine and trigeminal neuralgia? No. Will I be confused between tension type of headache and trigeminal neuralgia? No. Right? Will I be confused between cluster headache and trigeminal neuralgia? Somewhat, but not that specifically. So what is the closest differential diagnosis for trigeminal neuralgia? Snippo Kilo thinks it is pain is superficial. Then Nikhil thinks there is no loss of, there will be loss of sensation. Snippo, right, bang on, spot on, right. Okay, so now broadly, how we classify headaches? Headaches are classified into primary and secondary, right? So I'm only going to talk about primary headache. Secondary headache like raised intracranial pressure, head trauma, acute febrile illness, all of that. Leave it. Primary. Okay. Primary may important types are, one is tension type of headache. Tension type, right? The tension type of headache, how do we identify? There are few pointers in the patient's history. Okay. Is tension type of headache presenting in the form of few minutes, few seconds, few hours, or it generally patient has days of history before he presents to us? Right? It is a chronic type of headache. When they come to you, they generally have days to weeks to months history of headache, right? So I would say days to weeks to months history of headache. Okay. And the second point is it is non-localized. Like, don't say it is non-lateralized is the precise word. You don't see that it is unilateral, it is bilateral, non-lateralized, right? Or let me call it as bilateral, right? And the severity of the pain is not going to be very severe, right? It is dull aching. Mostly patients describe it as a vice-like grip around their forehead and the back of the head, right? So they describe it as vice-like grip. Someone is holding it tight. नहीं कह सकता हूँ कि ये दर्द है, like feels like someone is holding it tight. Vice-like grip. and this is most common in females. Females are more affected than males, and overall this is the most common primary headache. Most common primary headache, हम सबको कभी ना कभी हुआ है, right? All of us have experienced this. Tension type is 1. Okay, second is migraine. Migraine, like we all know, we differentiate it into classical and non-classical, or migraine with aura and without aura. Regardless of that, migraine has some features that is very important clue in your MCQs. When there is a clinical question, those act as important clues. Okay, what is that? The headache lasts for hours to days. How many hours? The minimum that an untreated migraine episode should last is 4 hours. If you have someone who had headache for 1 hour and it disappeared untreated, it's unlikely to be migraine. Right? It lasts for at least 4 hours, and the maximum it lasts, maximum of one particular attack lasts is 72 hours. That's the duration of attack. Right? I am again a patient of migraine and I can vouch for it. Like I have suffered 2-3 days of continuous persistent headache. Untreated 4 hours to 72 hours. Right? It is often associated with aura के बारे में बाद में करेंगे, but it is often associated with some additional features. Right? What are the additional features that you see? Often it is associated with phonophobia and photophobia. Photophobia. Right? It's often associated with nausea or vomiting. Nausea or vomiting. Right? And they may have plus or minus aura. Plus or minus aura. And another characteristic finding of these patients is that they have a, before the headache starts, right? Before the headache starts, they have a phase where they experience some vague symptoms. Then if aura is there, they go through an aura phase. Okay. After that, headache occurs. Okay. Again, after the headache gets relieved, they have another phase, right? So what do you call that as first phase? We call it as prodromal phase, right? They can have, it goes through stages. Migraine goes through stages. First stage is prodrome, which can last from hours to up to 48 hours. So even before they develop a headache, some hours to up to 2 days, they might experience some vague symptoms. Mostly it is like uneasiness, restlessness, and some of the patients, like I am experienced with my migraine, I can predict that I'm going to get my migraine tomorrow or day after tomorrow. I'm going through that phase. I can recognize that I'm in a prodromal phase, right? So most commonly they experience fatigue, restlessness, and mood swings during this period. Okay. And after this stage, right, they go to a next stage. Let me add a separate slide. Migraine stages. Next they go to aura if it is present. First is prodrome, we have discussed. After the prodrome, the next is aura. If it is present, right, where it is present in the classical migraine. In the non-classical or migraine without aura, it is not there. Important point to note here is aura usually lasts for more than 5 minutes and less than 60 minutes. Now this is very important. Why? Okay. Why this is important? You might have heard a term called as retinal migraine. What is retinal migraine? Patient presents with migraine headache and a unilateral vision loss. You might have heard of a term called as hemiplegic migraine. What is it? Patient presents with migraine headache and hemiplegia. Right? You might have simple aura like floaters, flashing beams of light in your visual field. Apart from that, you can have these more severe migraine, like there is something called as basilar migraine where they have gait unsteadiness, severe nausea, vomiting along with migraine. Those are all aura components. Okay. Now why this is important is, if you have, let me give you an example. You have a patient who presented with uniocular vision loss which lasted for less than 5 minutes. Then it is less likely to be a aura part of migraine, and it is more likely what you call as amaurosis fugax. Right? Then you need to evaluate for those causes. Okay, let me give another example. You have a patient who had headache and hemiplegia. He presented with that. But if the hemiplegia is persisting for more than 60 minutes, he may be actually going through stroke. And you need to remember that migraine is a risk factor for stroke. Migraine is a potential risk factor for stroke because there is vascular pathology involved and they are liable for stroke. So in that case, If it is persisting for more than 60 minutes, and if you just keep thinking it as migraine, you are losing the valuable time for treating a case of stroke, right? That's why we need to be aware that aura lasts for 5 to 60 minutes. More than 60 minutes, it's a red flag sign, it is not migraine. Less than 5 minutes, it's a red flag sign, not migraine. Okay. After the aura, they get into the headache phase. Headache phase lasts for 4 to 72 hours. And during this period, it is unilateral and it is very severe, often described as throbbing. It is not going to be dull aching like you see in tension type of headache. Unilateral and throbbing, right? Okay. After this, you go to the next phase, which is called as post-drome. Same thing that happened in the pre-drome, right? Lethargy, tiredness, fatigue, restlessness, irritability, mood swings, all of that they experience again in the post-dromal phase, which can also last for hours to 48 hours, like few hours to 48 hours. So sometimes one episode of migraine can literally screw their entire week, right? Just imagine 2 days with prodrome, then 1 hour with aura, then 3 days with headache, another 2 days with postdrome. Literally 1 week is gone, right? And if you want to abort an episode of migraine from occurring, right, best time is to give the abortifacient drugs for migraine or the acute drugs for migraine in the aura phase. Prodromal phase, most often we will also not be able to decide whether this is going to culminate in a migraine episode or not. But once you start seeing the aura phase, right, that's the right time to give the drug. You can prevent them from developing the headache. So if you have aura, it is good for you. If you don't have, right, this stage is bypassed and headache just starts, then can't help. Once the headache starts, you need to take the medicine. Okay. Now you have another important differential diagnosis for this primary headache. It is broadly categorized as TAC, T-A-C, TAC. TAC. What is TAC? What is TAC? TAC stands for trigeminal autonomic cephalgias. Trigeminal autonomic cephalgias. Okay. It doesn't mean that there is a pathology of the trigeminal nerve. These are primary headaches, right? We call it as primary when we don't know the cause, right? Secondary headache is when there is a direct established cause. Trigeminal autonomic cephalgias. So why do we call it? The reason is the pain is unilateral here. Just like migraine, the pain is unilateral. And the distribution is more in the distribution of the trigeminal nerve. To be more precise, the V1 segment of the trigeminal. I'm not saying the trigeminal nerve is affected, but the V1 segment is where the maximum intensity of pain is experienced by these patients, and it is unilateral, one-sided. It is generally going to be severe. Okay. Now examples for TAC includes trigeminal autonomic cephalgia. ट्राइजेमिनल डिस्ट्रीब्यूशन, सेफेल्जिया, हेडेक. ऑटोनॉमिक इसलिए बोल रहे हैं कि cranial autonomic nervous system is also affected. So what happens in that case? Patients develop nose stuffiness, nasal stuffiness, conjunctival redness, and tearing. The tears. That's why we call it as TAC. Trigeminal autonomic features are also there, and cephalgias. Examples for this are, you have cluster headache. That's the most common trigeminal autonomic cephalgia, cluster headache. Right, this is the most common trigeminal autonomic cephalgia. The second is what you call as paroxysmal hemicrania. Paroxysmal hemicrania. And the third one is what we call as Sankt and Suna. Sankt and Suna. So already someone had mentioned that it is the closest differential diagnosis for trigeminal neuralgia, right? Cluster headache, important points to note is that it occurs in episodes. And why we call it as cluster headache is there is seasonal clustering of episodes. Migraine na kabhi bhi aa jata hai. But this cluster headache, let me give an example, like mujhe hi patient samajh lo. So I will experience episodes of headache which generally last for less than 4 hours. So 4 to 72 hours we were thinking about migraine. Days to weeks to months we were thinking about tension type of headache. Right, here it is generally less than 4 hours. All of these are generally less than 4 hours. All the trigeminal autonomic cephalgia. Each episode lasts for less than 4 hours. Now these episodes that we are talking about, they cluster together seasonally. That means like, okay, this year Jan and February I got a lot of episodes. They occurred in cluster. Then after that I didn't have episodes. Next year na fir Jan and February or same season you call it winter, summer, it will appear as a cluster of like har din ya har alternate day, it appears as a cluster. That's why it is called as cluster headache. And I think you should be already familiar that in the question generally they mention alcohol as a precipitating factor, right? That is a clue. Alcohol is a precipitating factor for cluster headache. It can precipitate even migraine also. पियेंगे तो भी आएगा, पीना मिस करोगे तो भी आएगा. But if question is talking about alcohol as a precipitating factor, mostly is drawing your attention to cluster headache. Okay. And last NEET PG और INICET में एक question था the management of cluster headache में. Okay, cluster headache, there are few objectives. Like when you're treating the cluster headache, there are few objectives. One is currently patient is going through an acute attack, right? How do you help him come out of the pain for the acute attack? What is the drug of choice? That's the first point. Okay. Second, he is going through a cluster now. Like tomorrow, परसों, 2 दिन के बाद, 3 दिन के बाद फिर से headache episodes आते रहेंगे. So this cluster needs to be broken, right? To break the cluster, break the ongoing cluster, what is the drug of choice? And the third thing is long term prevention. Like जैसे हम migraine का prophylaxis देते हैं, we use prophylaxis for cluster headache also. So long term prevention के लिए what is the drug of choice? Okay, can anybody tell me what is the drug of choice for Tarakan Das? Right, 15 to 180 minutes. Yeah, there are two options you can think of. One is IV sumatriptan. You use it for migraine also, I know, but it has also been approved for treatment of acute attack of the trigeminal autonomic cephalgia and oxygen, O2. Okay, and the question that was asked in the INI was based on one of the recent publication which showed that IV sumatriptan is superior to oxygen in terms of aborting the ongoing episode of headache. So if they ask you which one is better, your answer should be IV sumatriptan. If they just ask you what is the drug of choice, I would still suggest go with oxygen because that is what is most commonly practiced right now. That study is not part of a guideline. It is one standalone study, but study clearly proves, when you look at the data, it clearly says that sumatriptan is superior when given IV. It is superior to oxygen. Okay. To break the ongoing cluster, the drug of choice is steroids, prednisolone. Steroids is the drug of choice, right? And for long-term prevention, the drug of choice is verapamil. There are various other drugs approved, but these are the important ones I want you to remember. Verapamil is the drug of choice for long-term prevention. For breaking the ongoing cluster, prednisolone. For acute attack, you have two choices, sumatriptan or oxygen. They ask drug of choice, go with oxygen. If they ask between the two, which one is better, go with sumatriptan. Okay. Then I want you to remember one point about paroxysmal hemicrania. Okay, paroxysmal hemicrania is where the headache lasts for much lesser. Like I was talking about less than 4 hours, and someone had already mentioned that 15 to 180 minutes. That's what is the typical story of cluster headache, right? In paroxysmal hemicrania, it is in terms of minutes, like 10, 20 minutes, 30 minutes, that's it. In terms of minutes, it won't last in terms of hours. Okay, and because it occurs intermittently, we call it as paroxysmal. Called hemicrania because it is unilateral. And a very important point that gives you a clue that this patient is having the paroxysmal hemicrania on the exam is they are very, very responsive to indomethacin. Indomethacin responsive, right? You give indomethacin and they respond like that. Indomethacin responsive. There are only two headaches where we use indomethacin, or they are indomethacin responsive or indomethacin sensitive. One is paroxysmal hemicrania. Can anybody tell me in what other condition we can use indomethacin? What other primary headache? What other primary headache we can use? What other primary headache we can use? The another primary headache that we can use is paroxysmal. Sorry, not paroxysmal. There is something called as hemicrania continua. Hemicrania continua. So it is a type of primary headache where headache is continuously present, not appearing as paroxysms. Easy to remember. Hemicrania word आता है तो indomethacin responsive होगा, right? Hemicrania उसके पीछे paroxysmal लगाओ या continuous लगाओ, it will be indomethacin responsive. So drug of choice for managing these patients is indomethacin. Okay. Now coming to the last part, SUNCT and SUNA. What does it stand for? SUNCT stands for short lasting unilateral neuralgiform cephalgias with conjunctival stuffiness and tearing. So basically those stuffiness and tearing is all about the autonomic symptoms. They're short lasting, unilateral. Why are we using the short lasting? We are not using the word paroxysmal. We are using short lasting, right? SUNA is nothing but SUNCT without the conjunctival tearing, but other autonomic features are there. Short lasting unilateral neuralgiform cephalgia with autonomic features without conjunctival tearing. रोते नहीं है ये patients बस. Okay. Why are we using short lasting? Because these headaches, point number 1, last for seconds, just few seconds, 2-3 seconds, 4-5 seconds, yeah, khatam. Okay, but because they last for seconds, they can come in long bouts, multiple bouts. आएगा, थोड़ा सा रुक जाएगा, फिर आएगा, फिर रुक जाएगा. So in that way, right, it resembles more like a trigeminal neuralgia. And second thing is, SUNCT and SUNA also can be triggered by cutaneous stimulus. Triggered by cutaneous stimulus. So in trigeminal neuralgia, if I stimulate the distribution of trigeminal nerve, it will trigger an episode of pain. Same can happen with the SUNCT and SUNA. Then how do we distinguish? That's a key point, right? How do we distinguish? Now this is a table that kind of gives you a full idea about what is the difference between trigeminal neuralgia and SUNCT and SUNA. Number 1, the site of pain in trigeminal neuralgia is typically V2, V3. V1 is paired. On the other hand, SUNCT and SUNA, it is typically V1 segment where the eye is like that segment is affected. The lower segment is relatively less affected. That's the first clue when you examine. Okay. Second, yeah, both are very severe pain, just lasting for seconds, but जिंदगी बर्बाद कर देते हैं patient का. Okay. Duration also will not be able to give you much clue because it generally lasts in terms of seconds. Okay. Important clue is that autonomic features. Generally not seen in trigeminal, but they are very common, right? Conjunctival tearing, redness, nose stuffiness, facial hyperemia, they are all being seen in SUNCT and SUNA. As the name says, they are autonomic cephalgias. But most importantly, when you are examining, this is going to be the clue. Refractory period. When you give a cutaneous stimulus, I told you, when you give cutaneous stimulus, both patients, trigeminal neuralgia as well as SUNCT, it precipitates the headache. Right? But in case of SUNCT, the moment you give cutaneous stimulus without any refractory period, it triggers the pain. On the other hand, in patients with the trigeminal neuralgia, there is a latency. You do the stimulus for a fraction of a second, patient doesn't experience anything, and then he experiences. That latency is a distinguishing point here. There is a refractory period present after giving a cutaneous stimulus. There is no refractory period in case of SUNCT and SUNA. As soon as you touch, it is going to trigger the pain. Okay, and there is no specific drug of choice for acute attacks because these are coming for seconds. So before you decide even to कि हाँ कुछ दे देते हैं क्योंकि एक attack आया है, the attack is gone, right? So it is only role of chronic preventive treatment, and the drug of choice for prevention of SUNCT and SUNA is lamotrigine. This is an MCQ which has been asked in previous exams, and trigeminal neuralgia we're very much familiar with, right? Carbamazepine and oxcarbazepine is what we generally use. That's the drug of choice for trigeminal neuralgia. Okay, now going back to the question, I have to tell you one important point. The pain in both these cases, SUNCT and SUNA, is generally superficial. It is not deep-seated. Because even in trigeminal neuralgia, it is the sensory component which is getting activated, hyperactive. So the sensory component which is hyperactive, that's why you're perceiving the pain. So it is going to be superficial. It is not going to be deep-seated. There will be no objective signs of sensory loss because it is the sensory neurons which are hyperactive. Even how do we treat? We either cut the trigeminal neuron or by injecting the substances to like alcohol and all to cause the rhizotomy or the nerve dysfunction. So as such, there is no sensory loss. So only thing is it is not a deep-seated pain. It is usually superficial. Okay. And the trigeminal neuralgia is more common in females, and SUNCT and SUNA are more common in males. More common in males. Okay, clear? Okay, now let's move to the next question. Crohn's disease presents with all of the following features except lead pipe appearance, transmural involvement, rectal sparing, perianal fistula. Okay, before you answer, I know all of you will be able to answer this question. My point is, what is the most common presenting complaint of ulcerative colitis, and what is the most common presenting complaints of Crohn's disease? Okay, so can anybody answer? Samir, yeah. If I notice that I'm going behind myself, I'll write on the other side, or I'll put a new slide. Yeah. What is the most common presenting complaint of Crohn's disease, and what is the most common presenting complaint of ulcerative colitis? आप बताओ कौन सा patient will come with bloody diarrhea? Is it ulcerative colitis patient or Crohn's disease? Which patient will come with bloody diarrhea? Ulcerative colitis का या Crohn's disease का? Right, so remember, bloody diarrhea is a typical presenting feature. Diarrhea as such is a presenting feature of ulcerative colitis, most common, but generally just diarrhea we don't suspect ulcerative colitis. When they tell that हाँ blood भी था, we'll start suspecting, right? So bloody diarrhea is the most common presenting feature. Crohn's disease, right, abdominal pain is the most common presenting complaint of Crohn's disease. Abdominal pain is the most common presenting feature of Crohn's disease. And we know basic things, right? The Crohn's disease is where there is aggressive fibrotic changes going on. So that is why that is going to be most likely to lead to fistula formation, stricture formation, and all of that. Ulcerative colitis, inflammation is restricted to mucosa and to some extent the submucosa. So stricture formation and fibrosis are less likely to occur. Right, but the mucosa is becoming very friable, and that is why bleeding occurs easily. That is why they present with bloody diarrhea. Right, now when mucosa is inflamed, you have a bowel, internal part is mucosa, right? Then you have the remaining part of the bowel wall, submucosa and other thing. If the mucosa is inflamed, what will happen to the hostrations that we see inside the colon? Inflamed mucosa will obscure it, right? It will obscure it because there were some dips and the inflammation has pushed it up, so it becomes like a smooth surface, and that is what leads to radiological appearance, what we call as lead pipe appearance, right? So lead pipe appearance, where do we see? We see in ulcerative colitis. Transmural involvement, very true, that is seen in Crohn's disease. Okay, what is the earliest site to start showing the changes of ulcerative colitis, or most commonly involved part of the bowel of ulcerative colitis? That is rectum, right? Most commonly involved part in ulcerative colitis is rectum. It starts in the rectum and then progresses proximally, right? Okay. In Crohn's disease, generally rectum is spared, true. But do you think it is always spared? It is always spared? The answer is no, it is not always spared. Sometimes it can be involved. In like up to 20-25% of the patients, it can be involved. General rule, it is spared, less commonly involved. And almost always the rectum is involved in ulcerative colitis. If you have diagnosed ulcerative colitis and you say that patient is not showing the involvement of rectum, there's only one possibility, two possibilities. Either your diagnosis is wrong, or the patient was treated with the sulfasalazine or other 5-ASA drug enemas locally. So that is why the rectal inflammation is gone down, and that is why when you do endoscopy, you're not seeing anything. Only those two possibilities, but otherwise rectum is always involved in case of ulcerative colitis. And the fibrosis, stricture formation, perianal fistula are all typical of Crohn's disease. So our answer is lead pipe appearance, right? So we are quickly going through some important images. Lead pipe appearance, you're familiar. There are three important radiological signs I want you to remember for Crohn's disease. Number one is called string sign of Cantor. There is something called as comb sign and creeping fat sign. You should be able to pick up the images. Okay, what are we seeing here? This is typical lead pipe appearance, right? There is loss of rectum is involved. As you can see, that rectal mucosa is smooth. It is not showing the hostrations. Here you're seeing the hostrations, right? But you're not seeing in the rectum, right? And as you see the remaining surface, right? It's all smooth. It looks like a pipe, right? That is why we call it as lead pipe appearance. So this is a typical image of a lead pipe appearance, and obviously this patient is having ulcerative colitis. Clear? Okay. Now tell me what is being demonstrated here. This is a biopsy specimen. I will show you a radiological image also. What you see here is that it is a segment which is affected by Crohn's disease. It has been resected. And do you see this fat which is like a shameless creeping on to the bowel wall? Normally the mesenteric fat is restricted to mucosa. It doesn't overgrow onto the bowel wall. Okay, like if this is bowel and this is mesentery, the fat won't overgrow it, right? The fat is only restricted to the mesentery, but here it is overgrowing, it is creeping on to the bowel wall. That is what we call as creeping fat sign, right? This is called as creeping fat sign, and this can be demonstrated radiologically also. When you do a contrast CT, you will see something like this. You can see the bowel lumen, right? And you can see the fat creeping here. So this is creeping fat sign, and obviously this is seen in Crohn's disease. And you have to also remember that this creeping fat sign will be segmental, because Crohn's disease is segmental, right? It is not showing a continuous involvement. Skip areas will be there. So wherever there is inflammation, creeping fat sign will be there. The segment of the bowel where there is no inflammation, you will not see fat creeping onto the bowel wall. Clear? Okay. Now tell me, what is this image showing? What is this image showing? This is most commonly confused image whenever I present it in the classes. It's most commonly confused image. What is this image? No, it is not toxic megacolon. Ernan, right? Yeah, that was creeping fat sign. Okay, is it string sign of Cantor? Is it string sign of Cantor? The answer is no. So what is it? We call this as Coombe sign. Coombe sign. Okay. Now this is your bowel wall, right? This is your bowel. Okay. And somewhere there is mesentery, and from there these are blood vessels which are growing towards the affected segment of the bowel wall. There is increased number of what we call as vasa rectae, right? These are all vasa rectae. They are increased more than normal, and that increase is also segmental. Wherever the segment is affected by Crohn's disease, we are seeing this increased vascularity, because inflammation, all inflammatory cytokines need to be delivered there. So angioneogenesis ho jayega, some blood vessels will increase. And when you look at this, does it look like a comb? The segment, don't you think it looks like a comb? It looks like a comb, right? That's why it is called as comb sign. And where do we see that? We see that in patients with Crohn's disease. This is not string sign of Cantor. Whenever I present it, mostly students say this is string sign of Cantor, because all these lines, they look like some strings of a guitar or a musical instrument, but it is not. Okay. Next, look at this image. What is this image? This is an image where you can see that there is significant stricture of the bowel. One segment there is stricture, and the strictured segment of the bowel looks like a string. Doesn't it look like a string? So this is what we call as string sign of Cantor. Okay, there are two reasons why this occurs. Number one, stricture formation, and second, because of this inflammatory cytokine attack, there is increased spasm of the smooth muscles in the colon wall. So there is contribution from the spasm also in addition to stricture. So if you give glucagon, which can cause smooth muscle relaxation, partially this string sign of Cantor may be reversible. Okay. In the past, when we didn't have aggressive surgery modalities available, we used to manage by looking at this by giving glucagon to help them pass some stools and not get obstruction. Now that if you notice something like that, cut karke bhej dete hain, right? But remember, it is called string sign of Cantor, which is the strictured fibrous segment of the bowel. Not to get confused between comb sign and string sign of Cantor. Okay. We will be taking up the last question for the day, and then we will connect tomorrow to take it forward. Okay. We have already discussed a lot about GB syndrome, so hopefully you should be able to give me an answer. In Guillain-Barré syndrome, what is the most common type? I've already told you, 85% belongs to one category. Which one is that? Which one is that? Right, AIDP is the most common, right? So we have already discussed about it. There are three types. AIDP, that is the most common type, and AIDP generally does not have any pathognomonic antibody associated with it, right? You should remember that less than 50% of the patients might have an antibody, but it is not specific for AIDP. That is anti-GM1. Less than 50% patients might have. Anyway, it doesn't add to the diagnosis. but the other types might have specific antibodies which can be MCQ, right? Amman type has anti-GD1A. It can have anti-GM1 also. Anti-GM1 यहाँ भी होगा, यहाँ भी होगा, यहाँ भी हो सकता है. It is like a non-specific antibody. But anti-GD1A is a specific antibody that I want you to remember for Amman, and same for Amsan. Amman and Amsan तो same ही है. Sensory involvement Amman में नहीं है, Amsan में है. That's it. Okay. And for the Miller-Fisher variant, you have anti-GQ1B. Anti-GQ1B as the important antibody that you need to remember. Okay, so anyway, this answer is very straightforward. Most common is AIDP. Option D is the correct answer. Okay, just few quick points or quick revision of GB syndrome so that you don't forget whatever we have learned today. Okay, point number 1. What are the basic features required for diagnosis? There should be progressive bilateral symmetry. I have already told you, should be symmetrical, weakness, starting distally and progressing proximally, or in other words, ascending. And it is typical element type, so there should be absent or decreased tendon reflexes. And hypotonia also. These are like absolute must. You have no absent reflexes or hyporeflexia, no tendon reflex, no hypotonia, unlikely that it is GB syndrome, right? You may be dealing with something else. Then there are other features which support the diagnosis. I have told you the progressive phase does not continue beyond 4 weeks. If it is continuing beyond 4 weeks, then it is not a GB syndrome, right? So usually under 2 weeks, the progression stops. After that, recovery hoga, yeah, patient will remain like that with all complications of being bedridden, being on ventilator and all. But he won't be progressing anymore after 4 weeks. Okay, symmetry is very, very important. Sensory symptoms should be mild, can be present, should be mild. It is absent in the acute motor variant, Amman variant. Yeah, cranial nerve can be involved. This is one again important point I forgot to tell you earlier, and it causes typically bilateral facial weakness. So some of the questions, this is also a clue. Bilateral facial palsy can occur. That's also a clue in some of the questions. Autonomic dysfunction, I have told you it can occur. Okay, they can have, yes, radicular pain. Yeah, there will be CSF pleocytosis. That means proteins are elevated, but cells are generally not elevated. So no, not pleocytosis. We can call it as albuminocytological dissociation. Why do we call it so? Because generally what happens is proteins increase or albumin increase, cells are also increased. वो कौन सा cell होगा, whether lymphocytes or neutrophil, that depends on the cause. But cells are also increased, protein also increased. But this is a condition where protein is increased and cells are not increased. So that is what we call as albuminocytological dissociation. You can see that. But this is a supportive criteria. It doesn't help you for further diagnosis. Most importantly, you can use the evidence of electrodiagnostic studies, Amman and Amsan, those electrodiagnostic findings, whether demyelination is a predominant lesion or axonal injury or both, that will help you the diagnosis. Most importantly, I want you to remember this. If they're asking MCQ, it will be based on this in the next examinations. Okay, you have any patient who improves within 24 hours of the onset of an ascending paralysis, it is not likely to be GB syndrome. For improvement also it takes time. Progression is also slow. Sometimes progression can be rapid, but improvement is generally slow. एक दिन से ज़्यादा तो पक्का लेगा. Usually in terms of days or weeks, not in terms of hours. If someone improves within 24 hours, it is unlikely to be GB syndrome. Progression, I have already told you, continuing to progress for more than 4 weeks, unlikely to be GB syndrome. Sharp sensory level, we will think of a spinal cord injury, not GB syndrome. Extensor plantar means कि UMN lesion है, something in the spinal cord may be responsible for the paraplegia, not GB syndrome. Areflexia, hyporeflexia is what we are expecting. If there is increased deep tendon reflexes, it is not GB syndrome, right? Okay, I think we will wind up for today. I am also a little fatigued and my battery is hanging on the thread because I had to move the location for the class. We will connect tomorrow again. We have another 60 questions to cover. Might take around 5 hours tomorrow. Okay, some of the topics may be recurring, so we will be rushing through those topics, and the important other topics we will discuss in detail. If there are unaddressed doubts, you can connect to me on the PW Meded Facebook group, tag me and ask the questions and we will solve it there. Okay, so I'll see you. Arunan, I have made a separate video on the GINA protocols for asthma. Diabetes, yes, there are questions based on diabetes, so we will touch upon the important points. I'll try to add some points on the GINA, some major changes that have happened in the recent 2-3 years time. Okay, I'll see you tomorrow again, same time, 6:30, and we will spend at least 5 to 6 hours tomorrow trying to cover the remaining topics. Okay, see you guys, have a good night, and thank you for connecting. Yeah, Curling's ulcer, Cushing's ulcer, these are all stress ulcers basically. The Cushing's ulcer is typically associated with head injury, curlings when there are burns, any other like sepsis also, stress also, you can develop ulcers, right? Sepsis induced, ICU care, critical illness, all of them can cause stress ulcers, but we have specific names for head injury and burns. Burns is what we call as curlings, and head injury or raised intracranial tension is what we call as Cushing's. Okay, so guys, see you tomorrow 6:30. Please connect and we will discuss more on important topics. Thank you all for connecting, and as I've already told you, doubts we will address on the Facebook group. Okay, Facebook group name is PW Meded on the Facebook. All the faculty members, all the 19 faculty members are already there, so we are waiting for you to pose your doubts. Okay. Thank you guys, have a good night, bye bye.